Good morning. We're going to go ahead and get our program started. I'm Leanne Sedone. I'm the President and Chief Operating Officer here at Suburban. I'd like to welcome you to Suburban Hospital and welcome you to our second annual Tara McMahon Behavioral Health Symposium. I'm really honored and thrilled that so many of you have come out to attend this really important educational session today. I've been a nurse for over 33 years. And over those years, I've seen an increase in the amount of people, both adults and youths, who come to us suffering from mental illness. And as a nurse, I have witnessed just how painful and absolutely devastating these situations can be for our patients and our families. And on a personal level, I've had family and friends also struggle as well, and I'm sure everybody here knows somebody or has a story. One family in our community, the McMahon family, is really taking a personal struggle and tragedy and channeling their efforts into helping others through education, and that's really the genesis of this symposium. We are so grateful to the McMahon family for the generosity, for providing this endowment that makes this symposium possible. And I want to thank our esteemed panel of speakers today for giving us their time and your expertise. Now I'd like to turn the program to Dr. Ashley Bone. We are so blessed to have Dr. Bone here at Suburban Hospital as the chair in the Department of Psychiatry and Behavioral Health. She is just an incredible physician and a wonderful human being. Your expertise, her compassion, and how she cares for our patients in crisis is truly commendable. She's a trusted partner, and we really lean on her to guide us and help us really grow our program and help as many people as we possibly can. Dr. Bone is also an assistant professor of psychiatry and behavioral sciences at the Johns Hopkins University School of Medicine. That is her residency alma mater. And her areas of clinical expertise include mood disorders, addiction medicine, and medically complex cases. So welcome, Dr. Bone. Thank you.
Good morning, everybody. Is everyone awake? Okay. I'm caffeinated and ready to go. I hope our speakers are too. I think they are. They've already been joking with me this morning. It's really wonderful to see everybody here this morning on this rainy, dreary kind of Saturday morning. I'm not great. I have these notes. I'm not great with notes. I'm not going to tell you all the wonderful things that our panelists have done because it would take up all of their time, to be honest with you, because we really have some wonderful speakers here this morning. Just a little bit of like housekeeping so that everybody knows what's going on this morning. So we are running, this morning it's going to be 9 to noon. Some people may come for part of it, all of it. We would love for you to stay for as much of this as possible. There will be kind of some light kind of breakfast items outside and some beverages. Just outside the door and kind of to the left are the bathrooms. If you need any help with anything, there are people in sort of the lobby area right outside of the auditorium who can help you find anything that you need. We're happy to help you find what you need. There are also, there's a table outside that has some takeaways for people that include pamphlets and flyers for some of the local community clinics and organizations that are in our community here so that people can kind of take those with them or access services if they need them. There are many different kinds of services. So Stephen is actually standing at the back. He's one of the individuals who can help navigate which programs might be helpful, or you can just take all of them and look at them at your leisure. So the three folks that we have today, we're going to be starting today with Dr. Pat Triplett. He's going to be talking about geriatric psychiatry. Our second speaker, he's just so you know kind of the layout, each speaker is going to talk for about 40-ish minutes or so, and we'll have a little bit of time for questions and answers after that. We'll have probably a pretty brief break. We're kind of a jam-packed session. We like to just pack it in. So there's really only going to be about a 5-minute break in between each speaker. And then after the three speakers, we will be going into a community panel discussion specifically on youth mental health. And there will be several different panelists of community providers and even individuals themselves who've had struggles who are going to be up here and answering your questions. So the second speaker, like I mentioned, the first one is Dr. Pat Triplett on geriatric psychiatry. The second we have is Dr. Michael Clark, and he's going to be discussing chronic pain and other issues related to that. And then finally, we have Dr. Liz Reynolds, who's going to be addressing youth mental health issues. Dr. Pat Triplett, I've actually known him for my entire training. He is one of my greatest mentors. He now avoids my calls terribly because I just call him with my troubles and my woes. But he actually is a wonderful member of the Johns Hopkins community. He is the clinical director of the Department of Psychiatry at Johns Hopkins Hospital and is a geriatric psychiatry specialist. He's an associate professor of psychiatry at Johns Hopkins School of Medicine, and Dr. Triplett has dedicated his career to improving mental health care for older adults. He has led initiatives in a proactive psychiatric consultation service and has been instrumental in advancing patient safety and suicide prevention in geriatric populations. So, without further ado, please help me welcome Dr. Pat Triplett.
All right, good morning. Getting our slides all teed up. All right, so, I'm going to be speaking about geriatric psychiatry today. I thought that's perfect. When Ashley asked me to do this, geriatric psychiatry, it's a broad topic, and I realized I have to narrow it down a little bit. So today I'm going to be talking about actually dementia. I'm going to be focusing on dementia and dementia management. I thought this is great. I know there's an aging population here around Sibley Hospital, and then in broader terms, it's a bigger issue for us nationally as well. And I thought this is perfect, and it also coincides well with my work in consult liaison psychiatry. So I've given these talks before, and I was putting things together, and it's kind of standard to put a case report together at the front end to kind of explain, these are the kind of things that we look at. As I was reading the case reports, I realized that I've spent too much time in academia. The case report was a 65-year-old woman who was airlifted in from a rural area for altered mental status, so she was very confused. There was a rumor that maybe she's had some dementia. She had a history of drinking too much, but a lot of the history was very unclear. Maybe a family history of dementia and mood disorders. She looked fearful. And then the thing that really brought it home, and this was why I presented this in a national meeting not terribly long ago, was that there was a rumor that she was drinking well water. And if you bring up well water in an academic setting, people get excited. Well water. Seriously, it's the whole place gets excited. The people working in the kitchen put their ladles down. Well water. So exciting. So many toxins, right? So much heavy metal. So many things that could be causing this altered mental status. So it's a bit of a zebra case, as we say in medicine. So all kinds of moving parts, very complicated. And I realized it doesn't generalize particularly well. It'd be a little bit like if I said, okay, I got a great case for you. In broader terms, I've got an idea for a movie where imagine a storm so big that it creates a water spout that lifts sharks out of the Pacific Ocean and spits them out on the streets of Los Angeles, and great mayhem ensues. So, as most of you probably know, that is the plot of the movie Sharknado. There are 5 sequels to that movie. So my goal today is not to bring you the Sharknado cases. I'm here to talk about, in broad terms, about dementia and dementia management. I'm going to keep, to the degree that I can, I'm going to try to keep our tornadoes and our sharks separate. If you want to talk Sharknadoes later, very happy to. Working in a hospital, but also working in an academic center, that is Sharknado territory. So these are the kind of cases we see. And as we talk about these conditions, you're going to see it doesn't take much before you start getting into very complicated scenarios. So that is my goal for today. I'm going to talk about dementia and dementia management, go through some of the most frequent types of dementia, and some of the behaviors. I'm a psychiatrist. These are the kind of things that we get called in to help with, and talk too about what are the things that we do to help medical teams and families too manage the psychiatric manifestations of dementia. So just to start with the broad facts, and these are updated as of this year. This is information from the Alzheimer's Association, which is a good starting point for anyone who just wants to know more about Alzheimer's disease and dementia more broadly. So currently in the U.S., there are 7 million people with dementia diagnoses, and that's expected to double by the year 2050. And looking back, the predictions so far have actually been tracking pretty well. It's an amazing statistic that we're going to have a doubling, and it has to do with the aging of the baby boomer cohort. So Alzheimer's currently is the 7th leading cause of death, and this has continued to increase, 146% in the last 25 years. Just by way of comparison, death by heart disease has actually decreased in that time frame. So dementia continues to grow and is going to continue to grow in terms of being cause of death. Currently, it's costing about $360 billion. That was last year, which is more than a doubling from around 10 years ago. And it's expected to top $1 trillion by 2050. So the latest estimate I saw was about $1.1 trillion. Currently in the U.S., there are 16 million unpaid caregivers, and that's up from around 10. That was 11 years ago. Actually, a little longer than that. And billions of hours of uncompensated care, and 83% of this comes from families. A little surprising, and this is surprising to me at least because of where I practice, 70% of patients with dementia live in the community. They're not in facilities necessarily. And another point, it's often the primary care physicians that are taking care of these patients. These can be very complicated folks, bring a whole host of behavioral issues to the table, and they're often being managed by very busy primary care physicians. So I'm not going to go into great depth about these, but I'm going to, I think, cover a lot of them. These are the primary causes of dementia. So the biggest, most frequent cause of dementia is Alzheimer's disease. And there are estimates that it causes 60 to actually closer to 80% in some estimates of all forms of dementia. And then vascular dementia is the second most common at 10 to 15%. But honestly, they really make up the lion's share, and the one at the bottom, the mixed dementias, are the ones that we often see. Usually, you can't know with certainty that it's a purely Alzheimer's case, purely vascular case, or some combination of the two, unfortunately, until autopsy. So we often see folks that are somewhere in that gray zone in between. Another fairly common condition that we see is dementia with Lewy bodies, and I'll talk a little bit about that. It's a different presentation, different disease course, which is 6 to 10%. And frontotemporal dementia, also very different. I'm just going to mention that one in kind of broad terms, along with normal pressure hydrocephalus. There are others as well. It gets more and more obscure. But these really kind of make up the lion's share of the forms of dementia that we see in the hospital and within the community as well. So what does Alzheimer's disease look like? So this is a schematic. The slide on the left is a picture of normal brain cells, normal neurons. The one on the right, it may not be easy to make it out, but there are two different kinds of disease processes or disease entities there. So the more kind of clumpy-looking yellow smudge, those are amyloid plaques. And the more kind of tangled-looking filamentous bundles, those are neurofibrillary tangles, something called tau protein. So these are the two things that continue to grow during the course of Alzheimer's disease and really kind of cause the damage that we see. And these are the things, too, I'm going to mention later, these are the things that are being targeted with interventions with medications. So tau and amyloid. Let me talk a little bit about clinical features of Alzheimer's disease. So just in terms of the fundamentals, the big one we see is cognitive decline. Memory gets worse, and different cognitive domains get pulled into that as well as the disease progresses. But we often will see functional decline as well. People become more dependent on family and other caregivers just to get through the day. And this harkens back to that slide about the impact of that. It's very expensive, particularly as the disease progresses. One thing that we've known for a long time is that it's not just those things. It's the neuropsychiatric symptoms that we in psychiatry are often asked to help with. And it's a broad range of things. It can include depression, anxiety, delusional beliefs, other kinds of psychosis, aggression, apathy, And it's these things that are the most distressing for families most often. It's not just the memory loss. As you can imagine, this can be devastating for families. So while you're watching someone slowly check out in front of you, that's a complicated form of grieving that you have to contend with. The person that you know and you love is leaving you, and they're doing it slowly over a period of years. And on top of that, you get these neuropsychiatric symptoms that they're causing a lot of day-to-day problems. So you can imagine the burden that families have to contend with. The timeline to Alzheimer's disease, it doesn't just suddenly appear. It's been estimated it can be 15 to 30 years of disease, so those plaques and tangles building up in the brain before you actually start seeing symptoms. And again, it's that zone where the disease is really first starting, where a lot of the prevention trials are being targeted. There's a condition, kind of a gray zone condition called mild cognitive impairment that a lot of patients might get labeled with, and it's a little nebulous. About 15% of those per year will eventually progress to Alzheimer's disease, but a lot don't. And different presentations, different symptom clusters seem to have a different risk for their progression to Alzheimer's disease. And some of them may not progress at all or may revert fully back to normal. Could be a complicated form of depression. I'm going to mention that very briefly later. And then eventually you get, as the disease progresses, you get the full dementia syndrome. So again, 7 to 12 years of gradual progression, that's up to the point of death. There are some studies that showed only a 3-year survival after diagnosis. Those were much earlier studies, and I think detection was a lot worse in those times. But for people that finally get to attention with a firmly established diagnosis, it's about a 7 to 12-year course of steady and in terms of the cognition, often almost stereotyped loss of memory. The short-term memory loss is usually the earliest symptom, so repeating questions, getting an answer, repeating the same question again. That's the kind of thing that families often notice first. Then as it progresses, you get aphasia, so difficulty with producing words, apraxia, difficulty with using your hands or fine motor skills, agnosia, difficulty recognizing things, and these things progress as the disease goes on. Often you'll see urinary and then bowel incontinence as the disease goes on, and gait disturbances, so they become unsteady. So falls become frequent, unfortunately. And at the late stages of the disease, you may even see a syndrome that looks like Parkinson's, as the substantia nigra and the nigrostriatal tracts get affected by those plaques and tangles and the losses that come with that. And then in late stages of the disease, they're essentially total care. And the most frequent causes of death are often dehydration, sepsis, or an aspiration pneumonia. So if a patient comes into us, that scenario I just briefly alluded to, of they're repeating themselves, they keep saying the same things over and over, we would start with a workup. So some basic labs, usually get a brain imaging, a CT or an MRI. The standard is to get at least one scan over the course of the dementia. We want to make sure that we're not missing something else. There are reversible causes of dementia. I mentioned well water as one, but that's low down on the list. But there are other things. Thyroid, vitamin levels can be involved in this. And getting the brain scan is useful. About 1 in every 20 times we find something we hadn't expected to see. So it's definitely worth the trip to the scanner. And the imaging itself has evolved, certainly since I was in training. The digital MRI now can be focused on Alzheimer's type dementia, looking at things like hippocampal volume, signs of atrophy, and something called the Fornix sign. And there are also nuclear medicine tests, amyloid and tau PET scans that target those two proteins that I mentioned before that really are the cause of the disease. And I'm actually going to show you a quick snapshot of what that looks like. So blood tests, we get this question a lot. Well, are there blood tests for Alzheimer's? There's not a reliable test for Alzheimer's currently. However, there are blood-based markers for the disease that have become more common standard. I think neurologists order these a lot more than a psychiatrist would. And actually, we just had two really great grand rounds at Hopkins on dementia, Dr. Bernala and Dr. Laketzos, talking about these markers and also some of the treatments that are coming along. And I'm stealing this shamelessly from Dr. Laketzos' talk. The p-tau 217 seems to be one of the more reliable ones. The paper I'm citing here was from 2020 with p-tau 181, which seemed to correlate with the disease pretty well, but it's actually kind of fallen out of favor at this point. There are also cerebrospinal fluid biomarkers. So it says A-beta, that's amyloid beta 42, so that runs low and correlates with Alzheimer's disease, t-tau, p-tau, and there are other studies as well. But you get that one through lumbar puncture. That's an invasive procedure and really not generally considered a standard part of the workup. But there are times when we do send those off and we're not quite sure what's happening. Every once in a while, too, we'll send someone off for neuropsychological testing. So those are primarily pen and paper tests of cognition. Sometimes it's more timed activities or manual dexterity assessments. But those are usually for ones where we're not quite sure what's going on. It doesn't quite fit the patterns very well. Probably the one I remember best was a few years ago. We had a man who worked for NSA as a cryptographer. So he was a foreign language specialist. So that part of his brain was enormous. He had an incredible capacity for language. And as his dementia process was going, we didn't know it was dementia, but he was acting strangely. And we thought, is he depressed? Or is this dementia? So we sat him down to try to suss that out. Eventually, with time and with serial neuropsychological assessments, we realized it wasn't depression. It was actually Alzheimer's dementia. But the thing that made it atypical was his language was so well preserved, and it was because he had that cognitive reserve to draw from. And we see that a lot with folks with high education, natural intellect, and special skills like that. So sometimes we'll take them in and get the pen and paper tests. I mentioned PET scanning. There's SPECT scanning as well. Lumbar puncture we don't routinely do. But if we're looking for something like normal pressure hydrocephalus, we might do a lumbar puncture. Electroencephalograms, it's a measure of brain activity, not generally something that we'll do if we're worried about delirium. So the woman with the well water, for example, she got an EEG. We were surprised when it was normal. But there are other patterns that we might notice as well and send patients off for an EEG. So just briefly about the genetics of Alzheimer's disease. So this is a very old paper. This is 1997, but it's a nice diagram, nice visual presentation of the genetic risks that we've known about for a while with Alzheimer's disease. So each of us has two copies of these, what are called ApoE genes. And what we've known for a long time is that if you have two copies of ApoE4, your risk for Alzheimer's disease is quite high. So that's the scale is the odds ratio, and I think the bottom line is age. So as we get older, our risk for Alzheimer's disease tends to go up. That's not really well captured here. But there's a different risk profile based on your genetics, your ApoE. So having two copies of that E4 allele greatly increases your risk. Having different combinations, particularly 3 and 4, also increases your risk from folks that don't have the E3 or E4 allele. Sorry, that's a little arcane, but it's going to come up in a second. It's actually knowing that is actually going to have some implications for treatment. So about vascular dementia, it can be kind of a grab bag in what you see clinically. Oftentimes you're seeing multiple strokes. Sometimes they're in particular places in the brain where you see unusual presentations. A stroke in the language center, for example, might make it difficult for them to speak or to understand things that are said to them. Very often what we see, though, is something a little more nebulous. It's extensive white matter disease. And this is where that mixed dementia picture comes in. We don't know if the vascular damage that we're seeing is because of all those plaques and tangles piling up, or is it small strokes, or is it some combination of those two? So this is where things can get a little hazy. Sometimes you'll see focal neurologic findings. I mentioned the language issues, but they might have weakness on one side or asymmetric reflexes or worsened problems with walking. And you can see a broad range of things, strokes, other signs of infarction and white matter disease on films. And again, this can overlap with the disease process of Alzheimer's. Dementia with Lewy bodies, we don't see as much. I think I mentioned like around 10% of all the dementias. They call it an Alzheimer-type dementia, but it doesn't really present that way. You're not necessarily going to see the memory trouble early. Very often you start seeing something that looks like Parkinson's disease, so tremor, problems with gait, masked faces, and things of that sort. So part of the dilemma early on is trying to differentiate this from a primary Parkinson's disease. As the disease progresses, you really can see a delirium-like state. Their sense of reality gets very altered. They will be experiencing things, hallucinations, delusions, that can be quite profound, and they can be kind of there all the time. It's really, it can be kind of a terrible state to be in, and as you can imagine, this often leads to psychotic and behavioral symptoms as well. They start acting on the things that they're experiencing kind of 24/7. But often there's this sort of up and down course to it, and often the visual hallucinations can be caused by many things. Just having someone show up with visual hallucinations, there are other things that can cause that as well, and I'm going to do my best to avoid that Sharknado that I put down there because there's a lot I could talk about, but I'm going to leave it be. So patients with dementia with Lewy bodies fall a lot. They tend to be exquisitely sensitive to a lot of the medicines that we use, especially the neuroleptics, and that announces itself often with the first dose. They get all kinds of side effects. But they do have these psychotic symptoms. They're hearing voices, they're having delusions, paranoia, thinking all kinds of things are going on around them that aren't real. And our first instinct is to try to use one of those medicines to help them, but unfortunately they do not tolerate them well. There are only about 2 or 3 medicines that we can use without causing all kinds of side effects. Another thing we often see is REM, sleep behavior disorder, so they're acting out dreams. They can be quite physical, violently thrashing around in bed, striking anybody that's in bed with them. But there are a few medicines that we can use. Quetiapine and clozapine can be used, but it does have some risk. There's a new medicine called Nuplazid that we can use that helps folks with this condition to some degree. I'll talk a little bit, too, about some of the medicines we use for memory. As this disease progresses, memory can be affected as well. And we treat the Parkinsonism with the same medicines that we would use to treat Parkinson's disease, so L-DOPA, things like that. And then there are different treatments for the sleep behavioral disorder as well, but that one can be kind of tricky to treat. So this is the data on the medication Nuplazid. Again, well tolerated. It's something we use for hallucinations and delusions in people with Parkinson's disease. We can also use it relatively safely in folks with dementia with Lewy bodies, and I've used that at least a handful of times. So frontotemporal dementia, very different disease entity. Alzheimer's and vascular tends to be later in life. Frontotemporal dementia often shows up when patients are in their 50s or 60s. And the overall pattern of what's going on doesn't become clear until much later in the disease course. And you can imagine how complicated it gets. We've got people who are in their prime earning years, the prime of their professional careers, and all of a sudden they start acting differently. They can be more disinhibited, saying things they wouldn't normally do. Sometimes we see essentially wholesale changes in their personality that goes on over a period of years. And the downstream effect of that is they lose jobs, they lose friends, they lose family, they can get into legal trouble. I'm going to not tell too many stories here today, but I've got plenty of examples of this. And unfortunately, a lot of times they just blame it on the patient. The patient has no idea what's going on, the family has no idea what's going on, but as we get the workup done, we realize this was actually a case of frontotemporal dementia. So there are imaging studies that help us to firm up a diagnosis of frontotemporal dementia. There are also some kind of findings on those pen and paper tests that help us point us in the direction of a frontotemporal dementia diagnosis. There are a broad variety of different diseases that kind of fit into this. I won't go too far into all of this. These days, we really kind of classify them into 3 categories. There's the behavioral variant, which the psychiatrists, those are the ones that we often will see. They can be disinhibited, apathetic, kind of the other extreme. Loss of empathy, so people that were otherwise caring suddenly aren't. There are some other behaviors that we see. And then as the disease progresses, then you start seeing trouble with memory. So it doesn't announce itself the way that the other conditions do. There's something called a semantic variant, which has to do in part with language, but it gets a little more complicated after that. And a non-fluent variant, primary progressive aphasia, so problems with language production. Normal pressure hydrocephalus is the last dementia type that I'm going to mention. This is one that we learn about in med school. So it's a combination of 3 things: dementia, urinary incontinence, and gait disorder, usually kind of a wide-based gait. And when we do a brain image of folks with normal pressure hydrocephalus, it's one of those ones that you can see across the room. The ventricles are very large. It's really hard to miss. And the brain tissue is kind of being pushed out into the margins. It's felt that this condition is likely underdiagnosed, and that the treatment, but also diagnosis, can be achieved through a lumbar puncture, taking off a large volume of cerebrospinal fluid that's actually under a lot of pressure, and it's treated with the placement of a shunt to help the flow of cerebrospinal fluid. So this is the shift point. I want to talk about the elements of dementia care. So we've talked about the dementia itself. So the way we think about this is we come at this from different directions. So we want to treat the cognitive symptoms, and there are a host of medicines that we use for that. Treatment of the neuropsychiatric symptoms, so the depression, aggression, psychotic symptoms. Again, these can be some of the most problematic elements of the disease. Support for the patient, looking at things like home safety. Driving is a huge issue, especially in the United States. It's a marker of independence, and when that is threatened, the emotional reaction to that can be really strong. And working with them on advanced directives and planning for the long term. Also, too, I'm going to mention support for family. This is critically important. I mentioned all those hours, those billions of hours of uncompensated care, but they need support. They need to know more about the disease process, what to expect. There are support groups. There can be options for respite care so that they get a break and are able to take care of themselves so that they can continue caring for family or loved ones. So I mentioned before that there's sort of a time frame where we try to prevent disease and prevent disease progression. So they focused on things like control of diabetes and hypertension in midlife, again, as the diseases are really kind of in their early stages, and the mindful use of benzodiazepines. So medicines like Ativan and Xanax, there are places where these are used kind of willy-nilly, and what we've learned is that prolonged use of these medicines, especially at high doses, actually increases your risk for dementia. And why that is, what the pathophysiology of that is, hasn't been fully worked out yet, but it's worth remembering, and it's something that we bring up with our colleagues in medicine a lot, that these are not, as I was told in medical school, all our medicines are poisons if you use them enough, so we need to be very careful about the use of benzodiazepines. And then I mentioned the Alzheimer's Association before. They've talked about the 4 pillars of Alzheimer's prevention. So diets and supplements, that's kind of a mixed bag in terms of their effectiveness. Stress management with yoga and meditation, physical and mental exercise, and spiritual fitness. All of these things are generally to the good. So the cholinesterase inhibitors have been around for a while. Acetylcholine is the neurotransmitter that's most often implicated in the disease. And these basically slow their breakdown. And this is, again, old data, but as you can see, the green and the yellow line are both Aricept, which is a commonly used medicine for memory, and the blue line is placebo. So this study was about a half a year long, and even during that relatively brief period, what they saw was it didn't stop the progression of the disease, but it slows it. And this leads to some interesting discussions with families about what are we doing? What are we trying to achieve here? Someone pointed out to me years ago, as you stretch those lines out farther and further, at some point there's a line that comes across that says nursing home placement. And is this what I want? Is this what my family member wants? Is more time in the nursing home with a longer disease course? And it gets, as you can imagine, these can be challenging discussions with families. But nonetheless, at the very least, it can give people respite and a reprieve to think about what they want for the longer term. So at this point, there are a handful of medicines like Aricept, Reminol, Razidine. They have FDA approval, and Exelon as well. For different stages of the disease course, we commonly use these. They can slow and stabilize disease, at least temporarily, but a lot of questions come with their use, and we have have to have very thorough discussions with families and patients about what we expect and what we can achieve. They do have a lot of side effects. GI upset is the most common. It says 1% syncope risk, but it actually might be higher than that. That's a fairly common one with these medicines. So again, families need to know about this before the medicines are started. And drug interactions, too, can be a real issue. There's a different class of a medication it's an NMD antagonist. It works differently from Aricept. The medicine, the first, and I think it's still the only one in its class, is memantine. But it, too, you can see that similar slowing of disease progression, but it doesn't stop it. It's not a cure. And the two can be used together. And again, that medicine also has side effects somewhat similar to Aricept, less GI side effects. So this is the latest thing that's come down the pike, and the two grand rounds that I mentioned are actually available on the Hopkins website if you're interested. It's the use of monoclonal antibody therapies. Really interesting. So Leqembi and Kisunla, I'm probably mispronouncing that, they target amyloid. They actually pull amyloid out of the brain. It sounds like very promising, but the reality is so far you still see clinical decline. So the disease continues to progress. And Dr. Leketsos in his talk estimated that this might slow the disease by 9 to 12 months in terms of the disease progression to the next phase. It's an intravenous infusion, so over 18 months, it's every couple of weeks. And patients need to get MRI scans as part of this. And then after that, it's kind of a judgment call. They get once monthly infusion, but also need to be following MRIs of the brain, and I'll show you in a second why. Oops. So this is from the paper, or one of the papers on Leqembi. You can probably see this across the room. So on the left is the placebo, so normal progression of the disease, so that's a lot of green and yellow. And then on the right is the lecanemab, Leqembi. The top one is at the start of the study, so that's very similar to the other two. So all three of those look kind of similar, so green and yellow. The difference is that bottom right part of the panel, where it's blue. And that's because Leqembi has pulled all of that amyloid out of the, not all of it, but a lot of the amyloid out of the brain. It's pretty impressive what it's done. So this was published in New England Journal of Medicine. It did lower the amyloid burden, as shown on the PET scan. The very busy panel on the left shows a measure of some of the other things that they looked at. And these are measurements of cognition and functioning. These two, much better than placebo, but still showed progression during the disease. And here's what I was saying before, they need MRIs. There's something called ARIAs, amyloid-related imaging abnormalities. And this can be swelling or bleeding, sometimes very small amounts, but they've noticed it in 20 to 30% of cases. And of that percentage, 3 to 6% are symptomatic, so much more significant effects of the ARIAs, and that's something that needs to be monitored. And here's where the genetics becomes important as well. So for people that have two of those ApoE3 alleles, they have an increased risk of ARIAs. For people that have one ApoE4, it's roughly twice that risk. And if you have two ApoE4s, the risk is even higher. So this is where knowing the genetics actually does have an impact on the treatment and the choice of treatment. And there are some places, too, where having two ApoE4s especially in the early use of this treatment of the disease, is a disqualifier. They don't want to risk the development of areas. So back to this neuropsychiatric symptoms in dementia. So again, I mentioned before, 90 to 100% of people will have some kind of psychiatric symptom. There was a study done through Hopkins in Cache County, Utah, and you can see here sort of the breakdown of the symptoms. So apathy, delusions, agitation or aggression, and irritability were the most common. But really, it's a broad array of things that clinicians and families end up contending with. So a question that we get a lot, Dr. Bone, I know, has gotten this one. It's pretty frequent. The patient's agitated, and that's a complicated thing to try to untangle. So it's often a combination of cognitive impairment, could be a psychiatric syndrome, could be depression, it could be a psychotic disorder, it could be a medical problem. Do they have urinary tract infection? Are they delirious from medications? Is it something in the environment? Sometimes, particularly for folks with Alzheimer's disease, a change in the environment is very destabilizing. The familiar things, the little cues, the things that kind of keep them on track, change when you come into the hospital, and that can be the source of the agitation, or at least a factor in it. And sometimes, too, it's the caregiving approach itself. And some of that has to do with the environment of being in the hospital, so it gets complicated. So our advice is usually, for the medical teams, is to stay away from the medicines that can cause delirium or make it worse, so benzodiazepines, opioids, and medicines that affect serotonin or dopamine or antihistaminergic or anticholinergic. It's a balance, though. There are times when the treatment that they need to reverse whatever condition they have has these side effects, but it just can't be avoided. In the inpatient room, we focus on the environment as well, so keeping the lights on during the day, not having the TV blaring. When I was in training, you could go room to room in the hospital and never miss a moment of Jerry Springer because everyone had it on, and it was, I knew too much about Springer by the end of my medicine rotations. So part of what our intervention there is, okay, let's turn it to the music channel. Let's, the beautiful scenes, whatever it is, something that is less agitating and maybe less distressing for them. And if you can, getting family and friends to stay with them to kind of reorient them can be very helpful as well. But it's a lot of what we do sometimes is very kind of common sense advice. There's a long list of medicines that we use for agitation. This is just a list of the non-neuroleptics, so medicines like Haldol and Zyprexa and things like that, and non-SSRIs. These often are medicines that we use very frequently, so antidepressants. There's a long list of other things that we use as well. I am not going to go into, this is definitely Sharknado country. I'm not going into that. And then we do have rating scales as well for agitation. And this is a list of the things that can kind of go into the sort of psychiatric symptoms that we see with Alzheimer's disease. And this neuropsychological inventory as well also has a measure of caregiver distress. So this is actually a very interesting thing, particularly for outpatient management, as you're working with families, is trying to keep track of how distressing it is for them as well, because you need to kind of have your finger on their pulse in addition to keeping an eye on the patient. So depression, initially I was just going to talk about depression the whole time today, but I'm just going to talk about depression within the context of Alzheimer's disease. But the reality is depression with aging, regardless, and even without Alzheimer's disease, depression with aging can look very different than it does in younger patients. And the most common thing that we'll see are things like anhedonia, so not enjoying things they normally enjoy, more anxious, more irritable, maybe agitated and restless, maybe even delusional thinking. But what we see less is depressed mood. Patients will not say to you, "I'm sad, doctor." They will have every other depressive symptom, but they will not have low mood. And it's easy to be fooled by that. If you have family members, friends that have all that constellation of that symptom cluster, but they often will not tell you that they have low mood. In fact, they'll flat out tell you that they don't have depression. And this can be a challenge. But we've known about this for a long time. This is a great paper that Peter Rabins and Kostas Laketsos, and others were involved in depression without sadness. And that is one of those things that we see in geriatric psychiatry. Everyone notices that there's a difference, something is wrong, but they will tell you they are not sad. So that if you take nothing else from this talk today, please file that one away. So that's an important point. Depression and Alzheimer's disease, Michael and I were just talking about this before. They will not stop studying this. It goes on and on and on. And I think it's partly because they get such a mixed bag of results. Some of the early studies, so Kostas' study in 2003 was really good, looked at Zoloft use, seemed to help with depression and Alzheimer's disease, but the follow-up study didn't show any benefit. The last chapter of this has not been written yet. For an Alzheimer's disease, treating depression, most often we're going to use an SSRI, so Prozac, Paxil. Lexapro is probably the one we use most often because of its side effect profile being favorable. But we can also use things like Effexor, Cymbalta, Wellbutrin, Remeron. These are different mechanisms of action from the SSRIs. They all have side effects. We need to be mindful of those things. And then this is something that at Hopkins we do a fair amount of. For really severe depression, ECT, electroconvulsive therapy, is often very helpful. I'm going to put a quick plug in. I'm not here to pitch anything, believe me. I got no disclosures. But I found this useful clinically, and that's the GeneSight assay. There's actually a panel on the Hopkins and Epic as well. And it's your genetic, how am I trying to say this? Susceptibility or response to not your response, that's not the right word, but it's how well you tolerate and how well your body processes psychiatric medications. So when these first came out, I think they're like $800 or $900 a piece. Now they're down around $300, and I think insurances increasingly are covering them. This is not, if you're in the red, if you have a medicine in the red column, it doesn't mean you can't use it. It just means you need to be thoughtful and careful about how you use it. Similarly with those in the yellow zone, green, you can use pretty much as directed on the label. But this is, as a clinician, I found this very helpful. It's a good place to start with discussions with patients and families. There's not a lot of casting around for will this work, will it not work, are they going to tolerate it, not tolerate it. So I am a fan of these. I am not here to pitch it, however. Psychosis in AD in Alzheimer's disease. So typically you don't see really profound psychotic symptoms until late in the disease. Early on you might see suspicion that things are being stolen because they're misplacing things. But it's really not until later that you tend to see hallucinations and really more profound delusions. So we tend to use the neuroleptics that I mentioned before. I'm going to skip over that. So caregiver interventions. So when we're talking to families about this, we have to come at it from different directions. So often a good starting point is education about the disease and what they can expect. Reassure them that we have ways of managing the dementia symptoms. Providing emotional support, and maybe that's not something you can completely achieve in the office, but there are other ways to get them individual and group and family supports. And often what we contend with is demoralization. It is not the path that most people have expected or wanted, but feelings of anger and guilt come along as well, and these can also fluctuate and recur and often can come up in a clinical setting. So 2 great resources for you. The Practical Dementia Care book is kind of an owner's manual for anyone who has a loved one with dementia. The 36-hour day also goes through a lot of scenarios and a lot of information, great information about Alzheimer's disease, what to expect, what the disease course looks like. So I would highly recommend both of those. So just to conclude, dementia is a huge public health problem, and it looks like it's going to continue to grow. And for us in psychiatry, it's these behavioral and psychiatric symptoms, which again occur 90 to 100% of the time, really are the thing that we contend with and accounts for a large portion of what we call the burden of disease. And the hopeful thing that I want to get across too is that many of these conditions are treatable. We may not come up with the treatment the first time around, but with persistence, we're often quite successful in helping patients and families. So thank you.
You mentioned supplements as a possible preventive. What supplements would be helpful?
So I was wondering, I actually had a slide I put in there on the supplements. The reality is none of them are shown to have much impact on disease progression. Unfortunately, I have a long list a long experience with folks taking too much of supplements, and sometimes putting too much faith in them. Ginkgo biloba was one that was popular a few years ago. I think the data on that were not supportive of being helpful. Was it vitamin D was popular for a while? These, again, I mentioned that all medicines are poisons. Vitamin D, A, D, E, and K, you can actually overdose on those. You can take too much of them. So I think when this comes up, I don't want to reject everything out of hand and say none of it works, but I think being cautious about what you pick is important, and having a thoughtful discussion with a physician about it is worthwhile. So I will admit, I don't know the data on lion's mane. My first reaction is, oh, it's another supplement, but the reality is, I don't know. I would need to look at the data to be sure. And that's one of the problems with with supplements is they're all off patent, right? So there's no drug company sponsoring studies to judge their effectiveness, judging how well they're tolerated, drug interactions, things like that. And also sometimes I'm speaking broadly, I don't know about lion's mane, but oftentimes too, these are not FDA controlled. So pill to pill, you can see dramatic variability in what the contents of a particular capsule. I'll need to investigate, honestly. I'm curious too, and that's the thing. I think when I was in training, we were taught to be dismissive of such things, but the longer I'm around, the more I realize we need to have an open mind about it. That's a good question about genetic testing. So APO, E3, and E4 testing, you probably noticed on the slide, it wasn't on the first workup slide. It's not something that we send off. And we need to be careful about getting information that can be misinterpreted. So even if you came up positive for APO E4, it doesn't necessarily mean that you're going to have Alzheimer's disease, even mid to late life. It's not a guarantee. Your risk is much higher, but unfortunately, when this is presented to someone who's worried about getting Alzheimer's disease, the natural reaction is to say, well, wait a minute, I have a double E4, and seeing it as a death sentence. So sending these tests off and interpreting the results needs to be done very thoughtfully. And this is still evolving as well. We run into there are other disease states. I'm thinking of Huntington's disease, for example. So that has a very distinctive pattern. And there are a genetic pattern. And there are times when it can be helpful for families to know about their risk for developing the disease. And the risk for Huntington's is much higher. So if you've got those repeats in your genetic code, your risk for getting Huntington's is very high, and you're probably going to get it. But not everyone wants those tests. They don't necessarily want to know that they're going to develop Huntington's disease. They can see it as a death sentence as well. And something that I was taught in training actually by Dr. Laketzos a long time ago was, from the outside, that looks like a terrible life. It looks like it's a death sentence. You're a shell of your former person. It must be miserable to go through life like this. But what he pointed out was, we don't know what their experience is. But what we do know is when we ask the patients about it, they're not unhappy. So I'm very cautious about getting genetic testing for patients for, well, Huntington's I'm leaving aside, but for Alzheimer's disease, because that information can get refracted in a very dangerous way. And we've had high-profile folks in Baltimore who thought they had Alzheimer's disease and died by suicide because they didn't want to, in a very public way. This was years ago, but so we need to be very careful about what we do and what the messaging is about the genetic tests and the results.
So next, we're going to welcome Dr. Michael Clark. So he is the former chair of psychiatry at Inova Health System and a faculty member at Johns Hopkins University School of Medicine. Dr. Clark is a nationally recognized expert in chronic pain management with extensive experience in consultation liaison psychiatry. He has led interdisciplinary programs addressing chronic conditions such as neuropathic pain and substance use disorders, and has contributed significantly to research on the psychiatric aspects of chronic medical illnesses. I really appreciate personally Dr. Clark being here as he's taught me everything I know about chronic pain treatment, and we are seeing it everywhere in our community. I'm very glad he could come here today and talk to us about it. Dr. Clark.
Well, thank you, Ashley, and thank you, Mr. McMahon and family, for hosting this event and making it possible. It's good to be back in Suburban. I've been here a number of times over the years and watched it evolve and grow and add services, and I can only hope that that trend continues threefold. So, all right, this is what I hope to cover. Really helping you to understand a little bit more about the opioid epidemic that you have heard so much about over the past many years. As you all know, it's not over. It has just changed forms. You probably do know or have heard about different aspects of these opioid settlement agreements, similar to the tobacco settlement agreements, where a number of companies, pharmaceutical companies, as well as distributors and pharmacy chains, were all found to be at fault in one way or another for the overprescription of opioids to this population. And certain areas were much harder hit than others. And now there have been consequences for that behavior. Some companies no longer sell opioids. Some are changing their policies by which they advertise or market them. Some are changing the way in which they are prescribed. Governments are imposing limits or restrictions on physicians or other prescribers of these substances. And it's a work in progress. Most recently, the settlement that Purdue agreed to or proposed and then had accepted has been overturned because it was thought to be just really not punitive enough given the magnitude of involvement. So that's in the process of being renegotiated. And so what will happen to this pot of money? And it's unclear because, as many of you know from the tobacco settlement monies, they wound up in all kinds of interesting places, some of which had nothing to do with smoking cessation or the consequences of smoking and cancer-related conditions. The same thing is true with this money. You'll see that it's not exactly clear where the monies will go to and to what degree. Most states are not disclosing how those monies are being spent. They just haven't done it. Others have laid out, this is the accounting of these dollars. For the most part, it looks like money is being spent on treatment programs, overdose prevention initiatives, but then there's the question of, should these monies be used for law enforcement? And most people in the treatment side of the equation would say no. We're not trying to punish people with drug addictions. We are trying to get them access to care. We're trying to prevent them from dying. We're trying to make them welcome to getting help. However, under some of the new changes of the current administration and budget cuts to different state and local governments, suddenly this is a pot of money that people are looking at as, oh, maybe we can use that for something that we don't have monies for. So you will see this shift, and hopefully people will stay true to the course. There's also a lot of money that just hasn't been spent because people are arguing about how to spend it. So how did we get here? You know, psychiatrists like stories, and we listen to people's stories all day long, and so I thought I would give you a description of really what goes into stories and how stories typically unfold. So there's something that's referred to as the meta plot of stories. There's the anticipation phase. As you start the story, there's a call to adventure. Then there's kind of what's referred to as a dream phase. There's this initial success, things are going well, and it's almost like you're invincible. Everything's going to turn out okay. Then there's the frustration phase, where you start to run into trouble, and you're not as successful. And suddenly you realize it might not go as planned. Then there's the nightmare phase, where the failures start to compound each other, and it really begins to feel hopeless. And you think, this is a disaster, and that's the way it's going to stay. And then the resolution. Against what appear to be all the odds, the person overcomes the burden, and you achieve some kind of success. So now let's think about opioids and how we got here. We started with this sense that pain was untreated, and it was, massively so. And if you were around 40 years ago or longer, you know that many people suffered in pain for long periods of time, even if they were dying. And that was the most, and you heard people say, we don't treat our pets this way. Our pets are getting treated better than our spouses and our parents and our children. So there was a call that went out essentially to treat pain, treat it more aggressively, use substances like opioids. And the initial group of patients that got treated were the terminally ill. And people raised questions about, well, what about addiction? What about the downsides? And we lost a huge opportunity to study people longitudinally and see what happened in a prospective design. Because people said, don't worry about it, they're going to die. What do we care what happens? They're going to die anyway. We're just going to make it, more comfortable and ease suffering. That's our primary goal. And the truth of the matter is that a lot of people did get relief, and it was an improvement. And palliative care got much better. And so that was the dream phase. Wow, these really are powerful medicines. And then we started to expand our use of them. And we said if people are dying in pain, what about people that are living in pain? They're going to be around for decades. What are we going to do about their suffering? So we said we've got to use these medicines there too. And suddenly it became obvious that not everybody was getting relief. And a lot of people were developing side effects. And a minority of patients were developing opioid use disorders. And so relief wasn't possible for some people. These were not panaceas. But opioids had this sense of, well, as long as they weren't packaged with Tylenol or nonsteroidal anti-inflammatory drugs, they weren't really toxic. You could die from an overdose, but they wouldn't destroy your liver or your kidneys, and so they had no ceiling. If you did it gradually, you could give people huge quantities. And I'm going to show you several cases of this behavior. And that's when we hit the nightmare phase, because we realized that, first of all, pain wasn't the only problem. It wasn't the only problem that patients in chronic pain had, number one. And in fact, people were now dying from overdoses. And some of those overdoses were from people that were abusing these substances and who had developed addictions and were not getting any kind of treatment. And oftentimes, the amount of opioid that a patient was prescribed dwarfed what you would see in the illicit abuse world. Individuals who were obtaining these off the street or getting them from illicit sources. They would tell you how much opioid they were abusing, and it was a fraction of what some of these patients were prescribed. So what's the resolution? What do we do now? It's important to understand that there really are a lot of risks to opioid prescribing. They're not necessarily the risks that you would think about. It's true that you can die from an unintentional overdose, and these medicines have many different drug-drug interactions. And clearly, the higher the dose and the more medicines you take, the more likely you are to overdose. But the duration of prescribing opioids, not the dose itself, is what increases the risk of opioid use disorders or addiction to opioids. The higher doses are typically associated with people who have high pain severity, but also depression, and who have a number of other life stressors, who are not coping well with things. Those are the people that get prescribed these medicines and given them in larger and larger quantities. It's also true that people with psychiatric disorders are at increased risk of being prescribed opioids, and it increases the risk of new onset depressive episodes. And the longer you're on opioids, the more likely you are not only to develop a substance use disorder, but also a depressive disorder. So in patients with no substance abuse history, the risk of misusing prescribed opioids increases in people that already have a depressive disorder. So there's interactive effects going in all directions, and it just is meant to convey that this is risky business. And the real problem is that people that are prescribing opioids are basically treating a complaint. I'm in pain. I hurt. I need something. When you survey prescribers, they don't have very high confidence in what they're doing. They're doing it because they can, but they don't really know what they're doing, and they are woefully unaware of the alternatives, both pharmacologic and non-pharmacologic. So, who gets opioids? And this is just meant to be my simple framework of different types of patients that you will see coming through your clinic who are on opioids, want opioids, maybe even need opioids. So, all these are cases from my practice over the years. 36-year-old man with low back pain. He leaned over sideways to pick up his briefcase. Had a sudden sharp pain in his low back. Got a CT scan. It was positive for herniated disc in his back at L5 and S1. Had a discectomy. Very common story. Didn't get relief. Eventually wound up being prescribed high-dose opioids. Had what's called an intrathecal pump, where medicine is delivered directly into the space around the spinal cord. And he got really great relief. It was removed because if you expose people to too high a dose of opioid, particularly intrathecally, you can develop a lot of weird neurologic side effects, and he did. So they took that out. Went on to have an anterior lumbar fusion, again with no benefit. Had facet blocks, but no benefit. This is a regimen that he came to me on. All right? Just soak that in a minute. So 2 different opioids, OxyContin and Dilaudid, in huge doses. Klonopin, a benzodiazepine. Restoril, another benzodiazepine. Bextra, a nonsteroidal that is no longer on the market. Interestingly, he had no aberrant drug-taking behaviors. He was probably the most compliant patient I've ever seen. He showed up for his appointments. He never ran out early, never, as far as I knew, never took more than he should. He was very pleasant. He was always accompanied by his wife. He'd been on this regimen for 17 years. And the only reason that he agreed to decrease the risk, because there was a lot of fear about what's going to happen to me, was that he and his wife wanted to have another child. And one of the side effects of high-dose opioids is that it makes you infertile. So he agreed to begin the taper. And this is a summary of some of the things that happened over a fairly long period of time, because things had to be done very gently and very strategically. And he had no obvious evidence of a depressive episode. He had no obvious evidence of any other problems. But as he tapered from these medicines, he did start to develop aberrant drug-taking behaviors. He started to run out early. He admitted that he had been taking more than he should. He was concerned about, would he become disabled again if he experienced the return of his pain. Eventually had to be hospitalized on the inpatient unit that I used to direct at Hopkins for pain rehabilitation, just to gain control and to provide more constant reassurance and to attempt to make some changes a little bit more quickly. Got him on a stable regimen, and things calmed down. I really am pushing the right button now. I'm getting no movement, so. There we go. Thank you. So this is an example of the legitimate patient. Just to give you a little bit more information about him, he's working full-time in a high-security clearance job in the federal government. He had been regularly promoted, gotten new assignments. He commuted 2 hours each way by bus from Western Maryland to the Pentagon. He was married with 3 children now, doing well. He was an elder in his church. He participated in Boy Scout activities. He performed all of his own chores at home. Mowed the grass, did the gardening, anything outside, painted the house, that was his. And it came time for me to leave Hopkins because I was going to move to Northern Virginia. There wasn't a single person that would prescribe this regimen. And so should he be on these medicines, given how he's functioning, or not? I eventually found one person that I'd known for many, many years who agreed to take him on, but said he would have to agree to follow his regimen, which was going to be different. And the patient reluctantly agreed because he didn't have any alternative. And as far as I know, he's done well. But it's for you to think about, is this something that we should allow to happen or not? Case 2, 55-year-old man with chronic osteoarthritis and multiple joints, x-rays definitive for the diagnosis, negative workup for other rheumatologic conditions, doesn't want surgery for joint replacement, no benefit with NSAIDs, improved pain on opioids, unable to tolerate any other non-opioid adjuvant medicine for chronic pain. Here's his regimen. Long-acting opioid, short-acting opioid. Ultra-short-acting benzodiazepine or anxiolytic, longer-acting benzodiazepine, and a stimulant. And what is happening in that mix? God only knows. He's been on the regimen for 10 years. Any attempt to change his regimen by people has resulted in rage. Very unhappy. He's a disabled construction worker. He has no other skills, no other source of employment. Married to a woman with chronic low back pain, significant financial stresses in the marriage. He has an adult child with a substance use disorder that lives at home, occasionally goes hunting with guns with his friends. The practitioner who sent him to me had inherited him from another prescriber. And he was reluctantly willing to prescribe this guy's regimen as long as there weren't any changes needed. So he continued the status quo, but that's it. Don't ask for more, don't ask for different. This is an example of the demanding patient. These are patients that don't understand the word no. And they want a practitioner to just fill their order. And so they want you to be a waiter or a waitress. And as a medical professional, healthcare professional, that's a boring job, and it's also an incredibly dangerous one. But these patients win because they intimidate, and they file complaints, and they get angry, and they make threats of all kinds. So eventually people get burned out taking care of these patients because they realize that they're not doing good. They're just doing something. And it isn't until you take charge of this situation that you have any hope in moving forward in a successful way. So these are patients that really need to understand the doctor-patient relationship. This is how it works. Yes, it's a collaboration, but I have a particular skill set and roles, and you have particular responsibilities and roles. And we will modify things when it's appropriate, not just because you want me to change your order. And there have to be consequences for inappropriate behavior. And you have all heard about the explosion of violence in healthcare, violence of patients on healthcare practitioners and staff. You can't tolerate that. So you don't put up with offensive behavior, and you discharge the person who's acting like a customer and not acting like a patient. Now, patients can have all kinds of difficulties and can have all kinds of distresses, but if they're willing to be a patient and work with you, you can work on those problems. Many practitioners feel like they can't discharge the patient because they'll be charged with abandonment or negligence, or a complaint will come in. That's why it's very important for them to understand that you discharge customers because that patient is no longer a patient and they are discharging you. You've given them your best recommendation, they're rejecting it. That is their right. So you're not discharging them, they're discharging you. You're happy to take them back if they change and accept the relationship as it should be. This is a guy that we were able to at least make some progress with. The whole goal is to discontinue as many of these as possible and to try to simplify the regimen and maintain a different status quo. As these changes occurred, though, the interesting thing was his pain and his functioning did not change one bit. Still complained bitterly, still did essentially nothing. But he did learn that this was the way things were going to go in the future, and so a lot of the aberrant drug-taking behaviors diminished. Case 3, 42-year-old woman with multiple somatic complaints, pain in multiple sites, had what we referred to as a pan-positive review of system, multiple complaints. This hurt, this ached, this was fuzzy, this was grainy, this was uncomfortable. Extensive negative workups over time, labs, imaging studies, multiple consultants. Everybody said, we can't find anything wrong. High levels of distress, frequent calls, unscheduled appointments. This is the patient that arrives in your clinic with multi-volume charts, has been to everybody else in the city, and nobody wants to take her back or maybe even talk to you about her. This is what she was taking: Vicodin, an opioid, Flexeril, a muscle relaxant, Baclofen, another muscle relaxant, gabapentin, an anti-seizure medicine, Celexa, an antidepressant, Seroquel, an atypical neuroleptic. Frequent requests for changes, but no aberrant drug-taking behaviors. She was just ever present and not getting any better. She was unable to work full-time as a realtor. She was married, but she had beliefs that her husband was unfaithful. Children were doing most of the work around the house and taking care of her. Couldn't predict any of her flare-ups, so she rarely did anything, social or otherwise. And the majority of time was spent on the internet doing research. These patients love the internet. And she only left the house for appointments. Now, she was leaving the house fairly regularly because she had a lot of appointments. They love to see people, too. And this becomes their whole world. And this world has been shaped by the health system. As we interact with these people, certain things get reinforced, and they do more of it rather than less. So this is an example of the high-utilizing patient, someone who really probably shouldn't be on opioids at all. And they really are characterized like this patient. They have very high levels of distress. They have multiple unexplained symptoms. Their medical history is truly overwhelming. Nobody has primary source information. And the chart is a game of that children's game, telephone, where you pass along, you whisper in somebody's ear. By the time you get to the end, the person has 5 different forms of cancer and has been diagnosed with 3 autoimmune disorders, and there's no evidence for any of that. And as a result, because nobody can really figure out what's wrong with them or how to treat them, they've failed everything. And so now people are running out of ideas, and they start to be given things that are truly inappropriate therapies or not even recognized therapies at all. So the most important message for caring for people like this is to recognize how distressed they are, to not get mad at them. Don't blame them because they don't know how to solve their problems. We're the ones that should be helping them solve the problems. And seeking medical care is really just the best approach for coping that they can come up with. And the system has embraced them in a weird sort of way. So they just get better and better at being that. So you have to validate the distress for them. So this is not the patient to say there's nothing wrong with you. This is to say I understand how upset you are. And I know that you are suffering. I know this not because of all the tests that have been taken, but because of the behaviors that you're engaged in. Nobody lives like this who is happy, healthy, and satisfied. And that's okay. I'm not mad at you for being sick, because that's a frequent thing they will say to you. But we have to get more people involved in a way that makes sense. So we can't send you hither, thither, and yon. We have to bring you into a team of people that are going to help address what we think the problems are. The first thing you really need to do is focus on, do these patients have a psychiatric disorder? And the most common one is a major depressive disorder that's gone unrecognized, or maybe a generalized anxiety disorder. 2 very treatable conditions if you can get the patient to accept the diagnosis and the treatment. You have to employ a very systematic approach because you are trying to show them that you're taking them seriously, you know what you're doing, and you're coming up with a coherent, rational plan. So you have to formulate the whole case, which means you've got to spend time with them and you've got to collect information yourself, and you've got to put those volumes of charts aside and your ordering pencil aside. And if there's nothing else that you take away from my talk, major depression is very common in healthcare, particularly in the high-utilizing case. So here's what happened to her medicines. Almost everything was tapered slowly and discontinued. Switched her antidepressant, added a low dose of an atypical neuroleptic that was different than and more potent than what she was on, scheduled more frequent appointments. People, when you say you got to see these people more frequently, there's an initial recoil. But it's enjoyable because you're starting to take charge of the case. You're starting to see them make progress. And as her depression improved, all of her somatic symptoms improved, and her functioning improved. And it was kind of like watching a flower that was starved for water come back to life. Last case, 28-year-old woman with neck and bilateral arm pain, MRI with moderate degenerative changes, an EMG, a nerve conduction study showed that she had carpal tunnel. Multiple medications, many people have that finding, by the way. Multiple medications without sustained benefit, medications that had immediate detectable effects, like analgesics, benzodiazepines, other anxiolytics. She liked the best because she knew something was happening. She was sensitive to being prescribed other psychotropic medicines, had side effects to everything, very difficult for her to tolerate any kind of adverse event. And she rarely followed advice. She frequently lost her prescriptions. She couldn't recount to you her regimen. She wouldn't follow up on other consultations or recommendations. It's just a chaotic mess. This is what she came to me on. Adderall, fairly significant doses, plus Vyvanse, a long-acting stimulant. Xanax, short-acting anxiolytic. Klonopin, longer-acting benzodiazepine. Tramadol, kind of mixed, weak opioid, but also analgesic. Celebrex, a non-steroidal anti-inflammatory drug. And her compliance with this regimen was non-existent and varied depending on what she was doing and when she would take stuff. So she was working as a nurse. I'm sure that's reassuring. Thankfully, with frequently missed shifts. She was single with a boyfriend who she said works a lot. I can only imagine why. Her mother was always giving me advice, was given extra time in school for exams. Her friends think that she's a lot of fun, but just way too sensitive. Life is generally a disorganized, chaotic mess, and she tends to report that she just feels better when she's on medications. Not a good outcome. This is the non-compliant patient. They really do need alternatives to opioids. The non-compliant patient kind of boils down to people that won't follow directions and people that can't follow directions. People won't follow directions. In some way, they're misbehaving. And they're misbehaving because they either have different beliefs than you do about their case, or they have different goals than you do. And it's important to know what people believe, and it's also important to understand, what are you here for? What are you hoping is going to happen? So many people just think your diagnosis is wrong. You just think you're either stupid or you don't know what you're doing and you haven't gotten it yet. So why would they take your treatment? Many people think that the risks outweigh the benefits, so they're too anxious to go that route. And many people have very low self-efficacy. They've been sick, they're not functioning very well, they just don't think they can do it. It's just too hard. People can have different goals in the sense that, and we saw this a lot in chronic pain management, their goal is comfort. I just want to feel better, I just don't want to hurt. Our goal is change. You need to be more functional. They may have the goal of somebody with an addiction. They want the medicine so that they can use it to meet that substance use disorder's demands. And some people just want more attention. You're their only social contact, unfortunately. They want to see you. They want to spend time with you. They want to tell you about their life. There was a secretary at Hopkins years and years ago who took care of a woman that eventually got referred to for me. Before we had caller ID, and it was first coming out, she paid for it out of her pocket to have it installed on her work phone so she could see when this woman was calling, and she would let it go to voicemail. Because once you answered the phone, it was a guaranteed half hour or longer. All right, people that can't follow directions, they're unable. There's something interfering. And most commonly, it's either psychiatric impairment or cognitive impairment. And depression is very, very common and missed and undertreated. Anxiety is very common in these patients. Occasionally, you'll see somebody with a psychotic disorder. They're subtle, and rare, thankfully. Then there's people that have cognitive impairment. Remember the bell-shaped curve of IQ? 50% of people are below 100. All right? It's not a judgment, it's just an observation. We forget that what we tell people to do is oftentimes more than they can grasp and terribly sophisticated. So, you gotta think about that. I got to the point where I didn't give people written instructions for tapers or titration schedules. I just said, take this for a couple of days and call me. I don't want to bother you. It's no bother. Why did I do that? Because a person left with my beautifully detailed instructions, came back a month later. They weren't on any possible combination at any step that I had ever outlined. I said, how did you end up on this dose? Well, I just did the best I could trying to remember what you had. I said, but I wrote it all down for you. They said, oh, I lost that in the parking lot. I said, why didn't you call me? That was a month ago. They said, I didn't want to bother you. I know you're really busy. Okay, just call me. A 5-minute phone call, very easy. Remember, these patients are on lots of medicines. So they are intoxicated or mildly delirious, can't think through the fog. There are people that have ADHD. There are people that have trouble paying attention and can't kind of stay on track, and so, they need a different kind of intervention. And then, as Pat told you, there are many people, as getting older, developing dementias of various kinds. And oftentimes you'll start to see that the presenting symptom of that dementia is they can't follow directions. They can't remember what you're telling them to do. And they still look pretty intact, but they're not. So this is what this woman came in on and what happened to all of it. Again, the goal was mostly discontinuation in a controlled, rational, engaging way. And once again, as she got off all of this stuff, her focus got better, her anxiety decreased, her function improved. So, where's the redemption here? Think about opioids and how we vilified them and anybody who uses them. The idea here is one in which there's lots of ways to punish people, and believe me, healthcare has found all of them. But redemption focuses on improving the status quo. The act is condemned, not the person. There's a reintegration of the offender, or the victim in this case, with the community. And there's a mutual process of trying to fix the harm that we've caused. So chronic opioid therapy, it's true, it's questionably effective. There are limitations in the data. There are anecdotal experiences that are not terribly encouraging, others that are. But the outcomes have generally been disappointing. Depressive disorders don't get treated. That makes the situation worse. Healthcare utilization doesn't go down, so it still costs a lot to care for these patients. Disability persists, so it costs even more. And think about comprehensive substance use treatment. It's the same kind of scenario. If you make it simple, it doesn't work. If you make it integrated and involve more expertise, it does work. That's what we need to focus on. So, the patient is reporting intolerable pain. The patient's stuck in this unproductive routine. The patient self-identifies as needing the medicine. And opioids have become a way of life, not recognized as a disruption of their life. The focus is on their wishes, not the consequences of their choices, and the functional disability is rejected as a temporary state. Eventually, you'll find the right prescription doctor and I'll get better. Eventually, my pain will be gone and then you'll see. I'll do everything just perfectly. So, we're trying to change the status quo by converting to function, not cure, from pain. And we're looking at the risk management and behavioral change, trying to block what is promoting poor choices. We no longer refer to pain as the fifth vital sign. We no longer say that there's a pain emergency for which we have to give medications or opioids. We're trying to prevent learning poor choices in our patients. and we're trying to deny opportunities for them to express those poor choices, and we're trying to alter the social attitudes about poor choices, bring everybody into a better place. So I'll finish with, top-down approaches are oftentimes not good for patients. They're good for leaders and for setting up structures and trying to level the playing field. But patients get labeled as a chronic pain patient, and they don't get formularized as a individual. Multidisciplinary treatment is a misnomer. It still infers that patients who don't get cured cannot be cured. And so therefore, they just need a little bit of everything. And it's similar to palliative care. We'll make you more comfortable. We'll try to make ourselves more comfortable taking care of you, but you won't really go anywhere. And as a result, any treatment with opioids can only end up in a stigmatized category. And I'm not sure we want to go that far. Bottom-up treatment focuses on the individual. Formulate their case, give them individualized treatment, describe all of their problems, not just one or two, try to address all those problems specifically, let the treatments evolve as you use them and address them and change them and hopefully get rid of them. And as a result, now you've defined roles in which opioids might very well be helpful. So the story ends with that resolution. Pain relief is not the only goal, and progress lies beyond opioids in our practice. Patients with chronic pain will remain. We're going to debate opioids forever. Physicians must provide care. That's what we do. We just need to do it in a better, more optimized fashion. So chronic opioid therapy is not really right or wrong, but it certainly has to be better than it's been. Thanks very much.
Good morning. This is my tramadol story.
Oh, okay.
I had a bicycling accident when I was 21, and I was strong as an ox, never realized I had back damage, and that went to chronic pain. Eventually, I wound up with a medical doctor. I won't say the name who it was, and his opinion was we weren't going to fix this. He refused to do an x-ray. Turn the clock forward. A bulletin came from this hospital saying they had hired a new low-invasive surgeon. So my care partner sitting next to me said, make an appointment. And I did that. Took one look at me, he said, did an x-ray, says, we need an MRI, but I'm sure I can fix this. Unfortunately, my pacemaker was non-compliant. Then another phone call from somebody at Suburban saying, there's a study. You can take a test. We're doing a study on MRIs and pacemakers. I got in the study. They took the MRI. I took it back to the surgeon. He said, I can fix this, but you need to get off tramadol. It's habit forming. I said, no, they lied to the physician. And I said, well, I've been taking it all these years, a low dose. It's okay for me, but it isn't fixing the problem. I can't stand up straight. He said, we need to get you off tramadol. So he gave me a schedule, and 2.5 weeks of hell of withdrawing from this non-addictive so-called drug. We finally had the surgery over 3 days, put stuff in my back, 1 day off, came in and fixed it. I gained 3 or 4 inches in height, and the pain was gone. My L1 and S5 were broken.
That's a great story.
It's a true story. And then he fixed it, and now I don't have that problem.
Yeah.
So tramadol is never in my life ever again, period.
Well, I'm glad to hear that, but more glad to hear that that the problem got fixed, and it just makes the biggest point of your story is that you got to listen to people. And if you've ever worked in an ER and a mother has brought in their small child and said, something's wrong with my baby, I don't know what it is, but something's wrong, you better not send that person home because it will come back to bite you. I've seen it over and over again. So I always ask patients what they think is wrong. I always ask if they have a secret theory that they haven't shared with me that I would be curious to hear. And I always ask them if I've addressed all of their concerns.
Dr. Reynolds is an associate professor in the Department of Psychiatry at Johns Hopkins School of Medicine. She's the director of acute psychological services and director of the pediatric medical psychology program. Dr. Reynolds specializes in child and adolescent mental health. Her work focuses on improving patient safety and behavioral programming in youth psychiatric acute care, and she's been a leader in implementing positive behavioral interventions and supports to enhance care quality. Dr. Reynolds is my go-to, actually, if I have acute care issues with kids, so I do appreciate she's here this morning, and I will turn it over to her.
Thank you for that wonderful introduction and for this event today. I'm deeply touched, and this community engagement is wonderful. So I'm here, talking about youth mental health. Obviously, this is a big topic, and so I'm going to try to cover a fair amount and pay attention to the time. I appreciate the clock here to keep me on pace. So my plan for today is to start by talking about common mental health conditions for children and adolescents, talk about the growing concern and the increased prevalence that we're seeing. I'll identify risk and protective factors, and then highlight some resources. Oops, I will get the direction right here, I promise. So what are the most common mental health conditions we see in youth? Really fall into three kind of main categories: anxiety problems, depression, and behavior problems. These conditions commonly occur together, and as it says here, for example, about 3 in 4 children with depression also have anxiety, and almost 1 in 2 have behavior problems. Anxiety and depression are more common with increased age, which is shown here on the graph, and behavior problems more common in the younger age group, ages 6 to 11. So I'm just going to talk briefly, right, about how we see anxiety, depression, and behavioral problems in youth. So with anxiety, right, this idea of excessive fear or worry that there's a perceived imminent or future threat. What we see behaviorally is this really triggers this need to flee or escape, associated with a lot of bodily sensations, right? Heart racing, tummy ache, sweating. And the response to perceived danger gets in the way of completing activities at home or in school. When do we consider fear and anxiety a problem, right? Anxiety is pretty common and actually can be adaptive in some settings. So when do we start to see it's a problem? It's out of proportion. It can't be explained or reasoned away. The fear gets really beyond the use of voluntary control. It doesn't change over time. It can lead to a lot of avoidance. And a lot of what I like to think about is, are the youth that I'm working with, are they able to do the things they want to do, live a life worth living for them? Is the fear appropriate for the child's age or stage? And again, this last piece about interfering with functioning. Anxiety can look a number of different ways in children and teens. So we can have anger, difficulty sleeping, defiance, right? This idea of can't or won't with our patients often comes across too, right? That can't or won't, I think, really applies to youth too that are experiencing anxiety. Chandeliering, which is a funny term of kind of almost these explosive emotional reactions that sometimes take us a while to figure out, gosh, is this an anxiety-provoking event for this child? Lack of focus, avoidance, and then over-planning. Why doesn't anxiety go away, right? This is probably overly simplistic, but I just want to speak to kind of how avoidance is so reinforcing, right? So in this image, right, the boy is afraid of a dog. The thought is, right, so we always think about our cognitive triangle, our thoughts, our behaviors, and our feelings. And so the thought is this dog is going to bite me. The behavior, right, is to avoid the dog. And then avoiding the dog leads to decreased anxiety in the moment, right? This kind of short-term game, oh, I'm at home, I'm safe, I'm away from the dog. But what we see here is that avoidance is really reinforced and the worrying persists, right? And so you have the still worrying, right, that persists. And so much of the treatment then is about beginning to challenge these thoughts, right? Challenge the thoughts, and in a hierarchical fashion, really approach the things that are causing us anxiety. Moving on to depression, when we think about depression in children and adolescents, some of the symptoms can be very similar, right, to what we see in adults. But we can also look some more of the kind of child-specific things that we might be thinking about. Irritability, for example, is a big one. Changes in sleep, difficulty concentrating, fatigue, low energy. Kids often also have a lot of physical complaints like stomachaches, headaches that don't seem to respond to treatment. And again, this idea of this reduced ability to function in the tasks that are essential for them. What are we looking for, right? We're going to be looking and kind of considering things like poor sleep, appetite, negative thoughts like nothing good ever happens to me, feeling unhappy, overwhelmed, urges to withdraw from others or stop doing the things that we used to enjoy doing, and in those different categories. All right, so moving on to behavior problems or externalizing problems. This term, either behavior problems, and then the broader idea of this externalizing is that externalizing is this idea that the behavior negatively affects people who are external to the child. The problematic behaviors with externalizing problems are directed outward and commonly include noncompliance, aggression, impulsive behaviors, arguing, rule breaking, and property destruction. Some of the kind of diagnoses we consider in this area are things like conduct disorder, oppositional defiant disorder. The big thing, right, these behavior problems are relatively prevalent and often are one of the most common reasons that children are referred to seek care, seek mental health care, why parents bring them in for services. I spent my day yesterday on a third grade field trip, and so I think it's important to remember what is normal versus atypical, right? I would say many of the children at the time, right, had some oppositional behavior on this. So there was definitely a few mean-spirited words I saw. There was some competition, and there were a fair amount of efforts to lie and cheat, I will say, from all parties involved. But so how do we distinguish between what we would say is like normal, right, normal child behavior, what we would see as typical versus when it's falling into that other like, hey, we should be worried about this. And so we want to make sure, thinking about it's the frequency of these behaviors, the intensity, how chronic it is, and then impairing. I did not diagnose anyone on the third grade field trip, I should say. Okay, so thinking about those general categories, and now I want to really speak to what we're seeing in this like really growing concern about youth mental health. I'm going to speak to the pandemic a fair amount here, but also I really want to highlight that these concerns about youth mental health were already emerging prior to the pandemic. So HHS data found that between 2016 and 2020, the number of children between the ages of 3 and 17 diagnosed with anxiety grew by nearly 30%, and similarly for those with depression. We see that suicide, this is always a sobering statistic, is a leading cause of death among youth in the United States. And on the bottom right here, we have the age breakdown from 10 to 14, 15 to 24, following in the second and the third leading cause of death. The CDC's youth risk behavior surveillance data highlighted that in 2021, 1 in 3 high school students experienced persistent feelings of sadness, hopelessness, which was a 40% increase since the last data collection. 1 in 6 youth reported making a suicide plan in the last year, which was this 44% increase. And 3 in 5 teen girls felt persistently sad or hopeless. And that's what's highlighted on the bottom left here, this from 2011 to 2021, how we're just seeing this impressively steep rise in this feelings of hopelessness and sadness among teen girls. There's also really been this accompanied increase in the demand for acute care for youth. So specifically, there's been increases in inpatient hospitalization for mental health conditions. For those between the ages of 10 and 14, hospitalizations for mental health conditions increased by nearly 50%. And inpatient visits specific for suicide attempts, suicide ideation, self-injury increased over 100% for all children. And this was particularly high for children between the ages of 10 and 14. So just really speaking to, right, we've got rising rates, and we have a supply and demand issue too, right, and that we have this real increase in the seeking of services. This is a little overly complicated, that don't need to spend too much time on this, but just that highlights that the demands further increased during the pandemic. And so what's been the response? What have we seen? In 2021, the American Academy of Pediatrics, American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association jointly declared a national state of emergency in children's mental health. And this declaration really highlighted the impact of COVID-19 pandemic, but also other existing challenges on children's mental health. And really, this was urging policymakers to take swift action to address the crisis. The declaration highlighted a number of different concerns, including the pandemic's impact, structural racism, increased mental health needs, and the real challenges accessing care. Following from this, the Surgeon General had an advisory come out in 2021 that highlighted how mental health is really impacted by a variety of factors. And this advisory was on youth mental health kind of generally, and I'm gonna highlight some of the kind of key things from this report. So this image here speaks to how we're considering a number of different risk factors, right, from the individual, family, community, environment, and society. And so we know mental health conditions can be shaped by biological factors, including genes, brain chemistry, but also environmental factors like life experiences. We know that some mental health conditions really cluster in families, but are often shaped by multiple genes. And whether an individual develops symptoms can really be further modified by their experiences and the surrounding environment. The environmental factors can really range from exposure to things like alcohol and drugs during pregnancy, birth complications, discrimination, racism, adverse childhood events, which we call ACEs, and these include things like abuse, neglect, exposure to community violence, living in under-resourced neighborhoods. These ACEs, these adverse childhood experiences, really can determine a child's sense of safety, stability, bonding, well-being. And with this idea of this kind of toxic stress, this can lead to long-lasting changes, including disrupting brain development, increasing the risk for mental health conditions, and other health problems such as obesity, heart disease, diabetes, both during childhood and then with future generations. This is just another image, how to kind of try to depict the layers of individual vulnerability, family environment, and social relationships that are not mutually exclusive, right? It's not just one category that really highlights, but these are intrinsically connected, right? And that's, trying to show the lines here, right? Our individual vulnerabilities interact with peer relationships, how we in our family environment impacts our individual vulnerability, et cetera. And so we're thinking about risk factors, but what are some of the hypotheses that have been generated to explain this increased prevalence in youth mental health that I described before? There have been a number. We unfortunately don't have a single answer, right? And we don't have enough data to fully understand what's happened, but there have been a number of hypotheses about this increased prevalence in youth mental health. The first one is this kind of more willingness to openly discuss mental health concerns, right? And so if we're more willing, right, is there kind of increased reporting and then increased rates? Let's see, other hypotheses, the growing use of digital media, and I'm going to talk about social media a little bit more here, increasing academic pressures, this limited access to mental health care, and I would also say kind of on that prevention side or kind of earlier intervention, increased health risk behaviors such as alcohol and drug use, And that what we see is kind of these broader societal stressors, like the 2008 financial crisis, the opioid epidemic. There's David Bren is a child psychiatrist who's talked about this generation of despair, right, that's had parents and grandparents that were impacted so significantly by the opioid epidemic. Rising income inequality, racism, gun violence, climate change, just as some of these kind of broader societal factors. Thinking specific to the pandemic, what happened during the pandemic, right? What were some of these kind of key risk factors that were identified during that time specifically? If you already had a mental health challenge before the pandemic, that even served to kind of increase, right, your likelihood. Living in an urban area or an area with more severe outbreak, having parents and caregivers who are frontline workers, having parents or caregivers at elevated risk for burnout, for example, due to parenting demands. Maybe you were caring for multiple generations. Being worried about the COVID, experiencing disruptions in routine, like not seeing friends or going to school in person, experiencing more of those adverse childhood experiences, experiencing more financial instability, food shortages, or housing instability, and then experiencing trauma, like losing a family member or caregiver. Okay, I'm gonna speak a little bit on social media, and I think I would this is such a hot topic, and I think something that we're kind of only at the beginning of understanding the full impact, right, on youth mental health. It's been pretty clear, kind of broad agreement that social media has some potential benefits as well as concerns for harm for children and adolescents. So in terms of any kind of benefits, we hear youth talk about finding a community that is more accepting than potentially what they're able to find in their in-person life, right? Or having an ability to connect in a way that it might be hard for them in person. Yet, we also know there are a number of different risks and kind of harms that are shaped by these kind of many complex factors here. So the amount of time children and adolescents spend on social media, the type of content they're consuming or otherwise exposed to, activities, interactions the social media affords, the degree at which it disrupts activities that are essential for health, like sleep and physical activity. I'm gonna really hone in on the sleep piece here in a minute. Different children and adolescents are affected by social media in different ways, right? Based on their individual strengths, vulnerabilities, and based on cultural, historical, and socioeconomic factors. Speaking specifically to social media and depression, this association that's been identified, there are kind of three main domains in terms of looking at this relationship. So the first is social isolation, and thinking about less time connecting with friends and family in person compared to previous generations. So instead, many use social media to connect, which can leave them feeling actually more isolated. Online social interactions may not be as rewarding, right, as in-person interactions. Social media may make the youth feel more excluded or like they're missing out when seeing others engage in activities and social interactions, right? It used to take a while to figure out that you weren't invited to the birthday party, and now it's within moments, knowing that you've been excluded, right? The kind of impact we see is this lack of healthy activities. So time spent on social media can lead to a lack of healthy activities. Physical activity, time spent outdoors, can help release endorphins, right? Can help alleviate symptoms of anxiety or symptoms of depression. It can also lead to this kind of sense of accomplishment and confidence, right? And so if we're sort of seeing this impact on this healthy activities, one of the first steps would be like, how do we begin to engage in these healthy activities again? And then the sleep, right? So research indicates that sleep deprivation is one of the most common contributors to depression, and social media can have this notable impact on sleep. Scrolling on social media can lead to stress, which can make it hard to fall asleep. And so this kind of unlimited to time, this time lost. And this time lost can be time lost to sleep, which we know is like so essential to a child, right? And we know that children's persistent short sleep increases risk for a number of negative, poor physical and mental health outcomes. This slide is borrowed from Michael Smith, another psychologist at Hopkins who has studied sleep really extensively and looking at, right, all these different concerns that we know is associated with poor sleep. Okay, so there have been some nice kind of general recommendations that have been made to think about how technology and youth, right, questions for families to consider, right? So how much time is being spent online in terms of content? Am I aware of what devices and content my child is accessing, right? What kind of, is it meaningful or constructive, right? What, are there healthier ways for my child to engage? Impact, I think this is a really important one when we're looking at that kind of individual differences, is my child, how do they feel after spending time online, right? Are they cranky? Are they down and out? Are they more impulsive, right? Or does it seem to have less of an impact? How can we guarantee or kind of assess am I losing time to some of those other important activities that are important for my child to engage in? Okay, so I want, we talked about these risk factors kind of in these broad general categories, and I want to now talk about the protective factors here. And this image might be a little hard to see on the right-hand side, but basically it's saying is when positive experiences outweigh negative experiences, a child's scale can tip, right, towards more positive outcomes. We can think about initial placement of that fulcrum affects how easily it is for the scale to tip towards the positive or negative outcome. The idea is that over time, cumulative impact of positive life experiences and coping skills can shift that fulcrum's position, making it easier to achieve positive outcomes. The image on the left really speaks to these kind of the risk factors, right? And then the associated protective factors. So thinking about within the child, kind of easier temperament, good social and emotional skills, optimistic coping style, family harmony and stability, supportive parenting, strong family values. With school, positive school climate that can enhance this feelings of belonging and connectedness. Life events, involvement with caring adults, support available at critical times. And then social, participation in community networks, access to support services, economic security, strong cultural identity and pride. So the Surgeon General report that I mentioned before highlighted really a number of kind of more at a societal level, what can we be doing, right, to support the mental health of youth? So I'm just going to highlight these briefly. Supporting really this, we have to recognize that mental health is an essential part of overall health. Empower youth and their families to recognize, manage, and learn from difficult emotions. Ensure that every child has access to high quality, affordable, and culturally competent mental health care. Support the mental health of children and youth in educational, community, and child care settings. Address economic and social barriers that contribute to poor mental health for young people, families, and caregivers. And that we need increasing timely data collection and research to identify and respond to youth mental health needs more rapidly. So that's thinking about kind of bigger picture. What are smaller picture, right? Things that we can do as a family, right? Finding how can we do self-care? How can we engage in kind of mood-boosting healthy habits, right? So thinking about this, if we were to, that was like kind of the bigger societal picture, how can we think about this within a youth and their family, right? So thinking about positive activities and relationships that can have a protective, scaffolding effect on mental health, lightening up, getting time outside, getting plenty of sleep, special time with parent and child, balanced diet, expressing gratitude, getting physical activity, acts of kindness, managing screen time, modeling self-care, and kind of creating a family culture around de-stressing. This just is like my general thoughts on where to start if you were concerned, right? So thinking about, again, when do we start to be concerned? We should look for the duration, level of distress, impairment. Helpful to get input from others who interact with a child regularly, to think about how's your child interacting across settings, right? For example, your teacher, how are they seeing a child's behavior in school, at daycare, on the playground? I highly recommend talking with a pediatrician early, right? Describing child's behavior and what you've observed, right? And thinking about that, then moving forward to referrals. We think this is kind of a levels of care, just to highlight, it's I think come out a little foggy here, but highlighting sort of the continuum of care, the levels of care that are available. So we have thinking about kind of primary care models, which is like having a mental health consultation or brief intervention within primary care. Outpatient services, that's where you think about seeing your psychiatrist on a monthly or kind of bi-monthly basis. We often think about weekly therapy. Their emergency services are in the middle, and then moving up from there, we think about kind of the intensity of these acute psychiatric services. Partial hospital programs, which was kind of mimic a school day, right? Thinking about from like 8 to 3 intensive outpatient programs tend to be briefer or fewer days a week. Inpatient psychiatric hospitalizations, where a child stays in the hospital, and the hospitalization is focused really on this kind of acute crisis stabilization. And then kind of the most intensive is residential treatment. Here highlight some of the existing resources that we have. These are mainly within our East Baltimore. I highlighted to you Bayview, but kind of in our Baltimore within Hopkins, what services are available. So at the Children's Center, we have an inpatient unit with 15 beds. We have a day hospital with 12 slots available. There's consultation in the emergency department and med-surg floors. Ambulatory, we have an intensive outpatient program, school-based and mobile home-based treatment that are available through Bayview. And then an ambulatory clinic called the Children's Mental Health Clinic. We're also connected to Kennedy Krieger and the Division of Child and Adolescent Psychiatry, and there's a range of services. The program that we work closely with is called the Developmental Behavioral Health, which offers neuropsychiatric services, developmental psychiatry, a specific OCD and Tourette syndrome program, a program focused on integrated health and behavior. There's also CASI, which focuses on autism, and the Center for Child and Family Traumatic Stress, which is really the trauma-focused clinic. There are some kind of growing intermediate care programs there. There is an inpatient rehab program focused specifically on really challenging presentations for patients with neurodevelopmental conditions, and then a school-based program. Just included a number of resources that I like to access regularly and often kind of recommend. The Society for Clinical Child and Adolescent Psychology, which is part of the American Psychological Association, has a wonderful website called Effective Child Therapy. And this really provides information about specific concerns, offers an evidence-based therapy list, a resource list, frequently asked questions. I find a really helpful section of advice for selecting a psychologist or other therapy provider, kind of key questions to be asking. And then they also offer a number of kind of brief videos teaching evidence-based strategies, more so in the parenting domain. The Child Mind Institute is a big practice in New York City, but has some of the best psychoeducation materials I've seen for children and adolescents, really kind of high-quality information that go through a range of different concerns. The American Academy of Pediatrics has a YouTube channel that has a series of videos for teens on mental health. And then, of course, I always want to highlight what our crisis services are available. So our 988 Suicide and Crisis Lifeline, which we know provides free, confidential, emotional support to people in suicidal crisis or emotional stress, 24 hours a day, 7 days a week across the United States. This is way more than we can consume, I think, in my last minute here of time available, but a number of self-help resources, books that I would recommend, and 2 great apps that many kids I've worked with have found helpful, Headspace and Calm.
Thank you for your presentation.
Yeah.
So you had a slide about factors that shape the mental health of young people. And you listed a lot of societal factors, environmental factors.
Yeah.
What about the huge increase in kids that are born this way?
Yeah.
I mean, I'd say I have 2 kids that both have anxiety. One has much more than the other. One lives much more normally, but the other is much more debilitated with it, and he was born that way. So what about that? What could be accounting for that huge increase of kids?
Yeah, no, it's a really great question. I wish I had more answers. I always feel like that part of the worst part of my job is how I have so few answers to these to these questions. I do think, thinking about the temperamental piece, that many children come into the world, with challenging temperaments, being kind of more anxiety prone. And we're, I think, beginning to try to understand what are the specific factors that contributed to that. And then how do you, if these are identified early, begin to create kind of environmental supports, in place to help that child with their specific makeup flourish to the best of their ability, And it might not look the same for everyone. And to me, that's really the important piece, is that there's not, I think, not one way to be successful, And thinking about, for this child with their specific makeup, how can we help them be successful? I think there's much more to learn in terms of, are there things that are happening at kind of more kind of environmental kind of toxin, I'm not sure if that's what you're getting, level. I don't think we know enough yet. I hope there's more research funding available to support initiatives that can help advance our understanding and help improve things for future generations.
Dr. Reynolds, thank you for your presentation. I have a really quick question, and it's in reference to your slide on questions to consider for screen use.
Yeah.
I wanted to know how much of this outreach and education is being targeted to parents of kids in daycare, early Head Start environments, and preschool, because this is where it starts. By the time they're in kindergarten, they're very adept at using screens. They're very exposed to screens. And then they go into a classroom, and I don't know if anybody has had kids in MCPS. They don't know what a chalkboard is.
Right.
They learn off of Promethean boards.
Yeah.
I mean, they are so adept at this. So would you be able to speak to that?
Yeah, no, my gosh, I think this is a really wonderful
Thank you.
question. It's something I've been thinking a lot about, is like how almost, smartphones, 2007, I guess, came out, And I think for a while it was like this Wild West. No one thought it was bad, I can remember, gosh, what year was it? I flew to San Diego for a conference and home, and on my way back, it was an 8th grade trip to DC, When it was, a bunch of 13-year-olds on my flight. It was in the red eye. And this was, gosh, I want to say 10 years ago, and almost every 13-year-old had their phone. And I was like, oh my gosh, they're all sitting together in the lobby, And now this has become more common. But I'm thinking 10 years ago, wow, we're at like a whole different stage here of every kid looking at their phone versus like interacting, even though we're sitting together, they're sitting together waiting for this flight. So I think, there's been like growing recognition for adolescents about these questions, Like what are parameters that we want to do? My kids aren't in Montgomery County schools. I'm up in Baltimore, but there's been a growing, as a families, are we going to get on the same page about when we're going to allow kids to have social media or phones, And kind of trying to do that as a community. I don't think there's been as much recognition for the impact, of younger kids, preschool. And I almost feel like this is like these interventions are kind of recognition and how the impact, I feel like we're like going down, And so I hope we get to the point, where we can understand that even kind of early on now, it's not uncommon to see, a toddler holding a phone, keeping them occupied, And what are the benefits? And in terms of the educational setting, what's the right balance, right, between using technology and the old-fashioned chalkboard, right? Yeah, it's a great question.
Hi, thank you for your presentation. It was awesome. So I don't want to open up a can of worms with ADHD diagnosis, but specifically to this topic, what I'm seeing as a pediatrician is that, in my opinion, a lot of the behaviors, as you said in your slide, manifest in similar ways, inattention and sleep problems, et cetera. However, in our society, it's a little bit faster and less stigmatized to treat ADHD with stimulants rather than the anti-anxiety or antidepressants, which originally had the black box warning, which unfortunately is still in people's mind. The ADHD meds are kind of normalized at this point. A lot of their friends do them, and so there's these, anyway, in general, that treatment track is kind of less resistance. And then you have the anxiety, CBT, resources are very limited and very expensive in our area. And so you look at someone with the same symptoms and one hand treating ADHD, which is, except for the problem with finding the medicines now, which is kind of relatively more straightforward and easier versus treating the anxiety, CBT, which is expensive, and meds, which are a little bit still stigmatized. So my question is, as a provider, how do you steer families who you really think the core issue is more anxiety and depression in that direction with all the factors I just said?
Yeah, no, this is such an important piece. I'm going to go back. I'm going to go to your question, but I really want to highlight the cognitive behavioral therapy, the expense, right, and the availability. I think one of the hardest things is that we've identified psychotherapies that we know are really effective, like CBT for anxiety, but the availability, the access is not there. And I know, while I work in Baltimore, I know what I see down here is that there's a proliferation of private practices, but not so much availability, right, within providers that take insurance, right? And so I think when we're looking at the societal factors, that's one of the big things that we have to address. Reimbursement rates, we have to be able to have more providers that are able to take insurance, right, and provide high quality care. We also have to train more people in evidence-based interventions, right? We have to grow our kind of workforce to be able to provide high quality interventions. So I thank you for highlighting that issue, because I do think that's a really important one. I think, in my mind, as a psychologist, right, I'm not working on the medication side of things, but I think so much about having a comprehensive assessment is really critical to be able to parse through some of those symptoms that we see as overlapping, right? Is the inattention there because a child is so anxious in the classroom that all their mind is doing is like threat, 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 right? Like I'm under threat versus like I'm, butterfly, right? Or, something else, right? The inattention that's not anxiety-based. And so to me, really kind of having that comprehensive assessment is critical. When I'm thinking about comprehensive assessment, the importance of multiple informants, right? So we need to have school teachers and multiple school teachers that's seeing a child across different settings. We need multiple parent reports, right, as well as the child report. All those reports don't have to agree, and to me, the lack of agreement is sometimes where we find the kind of aha moment, is understanding, right, how the child might be functioning, and what is evidence, right, that this might be more in an ADHD domain versus something that might be more in the anxiety depression domain. I also think it's important to look at kind of the ADHD versus anxiety depression over time, and that sometimes that kind of early identification of ADHD, right, if we don't identify it early, it can put kids at risk for anxiety depression. And then you get to kind of that middle school age, and it's a soup of trying to figure things out, right? And so really trying to take a developmental approach to think about when did these symptoms start to emerge, right, to get to understand those things. In terms of working with families, I think it's, I think in our previous talk, so much as what I would emphasize too is this collaboration with the family, right? And so also trying to understand if some of their kind of maybe focus on ADHD has to do with like, I'm kind of scared of these other, of these other diagnoses. And if we're able to kind of get to that, what might some of that resistance might be or what the fear might be, is there an opportunity for us to identify that and then kind of address some of those fears, right? And to go then be able to go from there. Yeah, gosh, resources, I have no answer for the wait lists for the psychological assessments, unfortunately. I think that, some of what I would love to plug is like, how could we grow more mental health services for children and adolescents here at Suburban and Sibley, right, Howard County, right? We have sources, resources that are sort of centralized, right, within Baltimore, Hopkins, but how can we begin to expand those resources? But no, I don't have a kind of a simple, I don't have an easy way to help a family get more on that anxiety, right, versus the ADHD. Unfortunately, if there's like I don't know if I have a simple technique, right, to think about how to help a family accept that diagnosis. Yeah.
We're going to squeeze in one last question.
Thank you very much. A very impressive presentation here. We started in on the autism arena, and we are working with adults with autism. And we started about 20 years ago.
Yeah.
And there's another component that we're seeing happening right now because there's been an aging population that started out as children when we started out that are now adults. And it plays in a bit to what the pediatrician was just mentioning too. There's a label, and we tend to like to label things.
Mm-hmm.
And ADHD is becoming much more familiar to people and being part of maybe everything that had been lumped together with autism. But there is something else, and it's a phraseology I'm not hearing as much in the professional area, but we're facing it every day as we hear about people's life experience, and that's neurodivergence. And how that would play into childhood. And we're hearing some of the stories about the fears, about the anxieties that are a little bit different than, or sensitivities to
Right.
textures and so
Right.
forth. But that has led into depressions as well, because sometimes people are bullied by that. And that's a whole arena for children that I see emerging because we're looking at adults now. And if there's any way of encouraging more understanding in that area, I would love to see it.
No, I echo that so much, and I as much as I was highlighting the impact the pandemic has had and sort of some of the negative ways, I think in the positive ways is I do think we're talking about mental health more, kind of much more in our society. I think it's much more kind of prominent in different settings, and so I hope that discussion, though, can extend right behind these like kind of three categories I talked about: anxiety, depression, behavioral challenges, into considering right all these other domains, right, including neurodivergence, right, and I think so much of what you're nicely describing is sort of this developmental psychopathology, right? Some of these kind of earlier challenges, right? The way sensory sensitivities, right? That over time can lead, speaking to the interactive, how you're accepted by peers or your teachers, how likely it is for you to be successful in a typical school setting, and how that can then lead depression over time. And so I think you hit the nail on the head, and my hope, right, is that we'll have continued attention paid to this important area. Yeah.
I just want to say again just how grateful I am to have met the McMahon family and to have them, I am always really grateful for individuals that try and kind of make lemonade out of lemons, and I so appreciate all the support that we've had from the McMahon family over the years. And I do, the person that we have actually moderating our panel today is Devin Larkin. She's actually Mr. McMahon's granddaughter. We're very appreciative to have her here. I will let her actually further introduce her role here, and then our several panelists. And I'm going to try and keep quiet.
Good morning. My name is Devin Larkin. I'm a board-certified behavior analyst, and the symposium is named after my little sister, Tara. She passed away due to suicide about 4 years ago. So this event is really important to my family, hoping to bring some light to the community. And before my sister passed, she had actually written down that she had hoped her story and her situation would help other people. So by coming here today, you guys are making light of that situation on her behalf, so thank you. I wanted to just give everybody on our panel a minute to just introduce themselves and what they do very briefly so we can pack in as much questions and discussion as we can. So if you just each briefly introduce yourselves and your role.
All All right. Good morning, everyone. My name is Karishma Sheth, and I'm the Chief Program Officer at Every Mind, and we're a mental health nonprofit providing a variety of services to our community.
Hi, my name is Caroline Zuba. I'm an undergraduate freshman at the Johns Hopkins University, and I have personally been impacted by mental illness, specifically with major depressive disorder. So I've gone through all the ranks of that pyramid you saw in the last presentation: inpatient, outpatient, residential. So I'm here to explain my experiences and hopefully tune you into what it is like and that there is hope and recovery is possible.
Hello, everyone. My name is Dr. Terry Griffith. I'm a psychologist, and I serve as a director of clinical services at Compass Health Center, their Silver Spring site, where we serve patients in PHP and IOP.
Good morning, everyone. My name is Dr. Holly Hinderly, and I'm a psychologist. I serve as the school psychologist for the Holton Arms School, which is just up the road. We serve girls 3rd grade through 12th grade, and then I also have a small private practice near American University.
Okay, so we'll get started. So my first question or topic for discussion is for Terry. What are the different levels of care and spectrum of services available to youth who are experiencing complex mental health difficulties?
Yeah, so I think one of the barriers for care is people just not knowing where to go, which is why I'm so appreciative that you guys have this event. And so for people who are looking for support, various levels of care and services that are offered to them. If someone is in crisis, there's different crisis hotlines people can access. There's mobile crisis hotlines that can come to your home. There's inpatient level of care when someone is needing hospitalization. And at inpatient, you're ideally being monitored for things like suicide, and people are more at higher risk. The tricky thing is that a lot of people get pigeonholed into inpatient or outpatient. I think everyone here is familiar with outpatient when you're seeing a therapist maybe 1 or 2 times a week, but really a good amount of individuals kind of get lost within those 2 levels of care, and they really need a level of care like PHP or IOP. So what's really great about PHP is partial hospitalization, where patients can go for 6 hours a day to get holistic care. And IOP is where patients can go for part of the day, about 3 hours, and also get that same level of holistic care, but still integrate in the community with school and with work. So lots of different services, and I'm hoping that we can give more education around what those services entail.
Great, thank you. Yes, both those levels of care are very important. My sister actually did both of them, and it does give people, instead of being fully inpatient, living in a treatment center, like you said, a chance to live at home, go in, be not just in a hospital setting. They can have the comfort of their home, they can still see their friends, they can still be out and about, all getting the care that they need, so that's really important. And I think a lot of people aren't aware that that's an option, but of course it depends on the diagnosis and severity. I don't know if anyone else had anything they wanted to add to that subject. Good? Okay. So my next discussion point is for Holly. What do you see as the biggest unmet mental health need among students today, and how can schools better support it within their existing resources?
Right. I think, as Dr. Reynolds pointed out, the rise of anxiety in our children, I think, is the biggest issue that we're facing today, as well as social disconnection. And I think the pandemic put a light under that fire in terms of disconnection for many students. There are some that felt more connected during COVID, but I think they were far and few between. So what schools can do, I think, is a number of, I think of it as a multi-pronged approach, both primary and tertiary, in terms of obviously providing mental health services to the best that they can, to the best of their ability, having counselors in the school, but also educating parents, having educational programs for students. One of the things I found most helpful is having speakers come in and talk about their own experiences with their mental health and how to get services. People like that are on this panel talk about the panoply of services that are available, and empowering students to refer their friends. I always tell students that they are the first line of defense. They are going to hear about their friend having struggles way before I do. And the goal is not for them to take it on and try to be their friend's therapist, but to know what the avenues are and where to refer their friend for support. So.
Definitely. I think I noticed myself that a lot of the schools, I live in Florida now, so my experience is a little bit different, but living in Florida, a lot of our schools are short-staffed when it comes to school counselors. I had a client who just had a very chaotic home environment, and I felt like she needed more than my services. She needed a school counselor. So I had made the referral to her teacher, hoping she could see her counselor, and they basically just told me, no, there's no access to help with that. So I'm hoping, as mental health, especially youth mental health, becomes on the rise, that maybe we can get more funding, reach out to your local people to realize that our schools need more support to hire more school counselors, get more services, because some kids, that is their only option, really, is the services they have at school. School is their safe place for a lot of my clients, and I'm sure a lot of your students. So that's really important. But again, they're friends too, reaching out. We had some of my sister's friends were brave enough to reach out to us when they had noticed things with my sister going on, that my family, especially if you have a young college student going to college out of state, you'd possibly have no idea that your child was having a hard time because they don't want to tell their parents or their older sibling. And so teaching your children compassion and empathy and to be brave and reach out if they see someone struggling is definitely really, really important. So thank you for mentioning that. All right, so my next point is for Caroline. What does the process look like if an adolescent is admitted and needs to seek outpatient or inpatient care for a psychiatric condition?
Yeah, so usually you start out with outpatient care, which is usually with a therapist. And it can take a while until you find a therapist that matches your personality, matches the needs that you have. And that can be a little frustrating right off the bat. But the person that really got me into the loop of therapy and external resources was my guidance counselor. Because one of my friends and some of my teachers were suspicious that things were going wrong in my life. And so after getting checked out and talking with my guidance counselor, she was the one that catalyzed talking to my family, including my mom into the symptoms that were happening because I was very good at hiding it. So after realizing the extent of how self-injurious behavior and suicidality really spiraled into very severe concepts where they weren't just hypotheticals anymore, they became a reality, that's when inpatient was necessary. And the whole process there, it's a long process because you start out in the ER, you go to a hospital like Suburban, and once you get in the ER, they kind of do an intake assessment, and they have a social worker come who really assesses your state and assesses how severe is this. And if they find that you are in a crisis scenario where you could be a potential risk to yourself or others, at that point, then you are admitted into an inpatient facility, which usually this is against somebody's will, or it's something they don't want to do. And they usually call this a least restrictive environment. So they want to put you in a location of treatment where you're not going to hurt yourself, but you still have the most freedom. So inpatient facilities tend to be one of those places where you are very restricted because of the threat you pose. So essentially, inpatient can be a relatively difficult experience depending on the hospital you go to. I went in and out of 7 different inpatient hospitals, and I've found that some of them are a lot better than others, and some of them are just catastrophic in their quality. There's a lot of issues with them, and I know we'll get into that in the next few questions, but one thing I would recommend if you would like to after this is if you'd like to come and talk to me if you have a child or a grandchild, or if you yourself are going through an issue and you'd like a recommendation on which hospitals to attend with good inpatient facilities, because some of them, you never know if it's your first time, which places are going to be more harmful than good in retrospect. So yeah, that's what I'd say.
Yeah, that's definitely a great point. Not all hospitals are created equal, unfortunately. I don't know if anybody has anything else they want to add to that.
Hi. So I figured at some point people actually might wonder, well, what do we offer here at Suburban? So I thought it's important to just let people know what is offered here. We don't actually have a child psychiatric unit here at all. We have a pediatric emergency room. So many individuals in the community in crisis come into our pediatric emergency room where they're seen by a pediatrician. And if there is some kind of behavioral or mental health problem, they are evaluated by a crisis worker who is a psychiatric social worker. They are pretty much determining if inpatient is needed or not needed, if partial hospitalization is an option, if it's not too severe a case, then they might be offering resources and things like that. But one of the things that I think has been a bit devastating to our youth during the pandemic with the lack of resources is that we have had some individuals stay in our emergency department for several days waiting on a hospital bed because they cannot safely leave. I also just in your comments, Caroline, I so appreciate your experience. And I also, as a psychiatrist, get very frustrated when the resources I want to send people to are not available immediately. And not just as a professional, but I was listening to Dr. Reynolds and her talk, and I am a psychiatrist. I'm also a mom. I'm a mom of 3 girls. And my oldest daughter has autism, and my middle daughter has anxiety disorder. And so I'm on the edge of my seat listening to Dr. Reynolds. But I will tell you, I also had a delay in trying to get my middle daughter a therapist. I'm a psychiatrist. You would think I have, whatever at my hands. I don't. I'm just like everyone else. I'm human. And so I actually really found a lot of benefit from the school counselor. It was so helpful. Thank you so much for what you do. And the way that MCPS is structured, my daughters are in public school, but so the counselor is actually split between schools. They're not always fully dedicated to the one school. Our school counselor was fantastic. I hate to say this, but you have to know the lingo. So there are all these legal things that they're not allowed to recommend and this and that, and I finally just said, listen, off the record. Where would you send your child? What if this were your child? So we actually, my daughter's in individual therapy. She's doing well. She has not gone to a higher level care. I know what those are if needed, but the school counselor is what really bridged that gap to get her into individual therapy, and it was so helpful. So sorry but I just wanted to let you all know that it is important to kind of, as soon as you know about these things, the school did not know about these issues. We just thought we had a defiant middle child syndrome, and except for she had 20 health room visits because there was always some medical thing going on, and I was like, that's anxiety. Anyway.
Because thank you so much for sharing that. As school counselors, when we see the kids all day, every day, and we know there's an issue, and it's so hard when parents don't want to partner with us. No problems here. No, she's fine, and we're taking care of it. And so I thank you so much for saying, utilize us. We're here to help. We want to bridge. We want to have that ongoing communication with the outside therapist, make a referral, give you resources. But so oftentimes I think parents are hesitant about that. And so thank you.
Yeah. If I can also just add something, that there's a lot of organizations like Everymind in Montgomery County that are providing school-based mental health services. So it's also not only hopefully falling on the school staff, who you have the expertise, but most school staff do not when it comes to mental health, right? And so we can provide services in the school communities, organizations like ours. And one of the really critical things that we offer as well that I think is important is focusing, and I know Dr. Reynolds touched on this as well, is prevention and early intervention, and starting with education, right, around mental health and mental wellness, and that it is just as important and drives and informs your physical health and wellness. And so an organization like Everymind, some other community-based organizations can come into schools and provide that education for students, for staff, for parents and other caregivers as well. So really ensuring that we have the resources and the services along that continuum of care and that we're accessing them is really important, because while there are wait lists and demand everywhere, and we all know that and are aware of that, there's a lot of out there as well that has capacity and can be accessed.
Yeah, That's a great point. You actually just answered the next question I was going to ask you pretty much. So great job. But yeah, I always tell the families that I work with, I told them to get on every wait list, get on every single wait list, all of them. And you never know when a spot will come up. We have a really good psychologist that diagnoses in Florida where I live, and her wait list is always quoted at being over a year. I can't tell you how many families, again, this is in Florida, but I imagine it's not that different here. I can't tell you how many families were seen way earlier than a year because she had a cancellation. So always, always, always get on the wait list and always ask to be on the cancellation list. Like, hey, I'll come in sooner if you have a cancellation. You know, I'll clear my schedule. I'll get in because the earlier the better. I mean, it's not gonna, at the end of the day, it's not gonna hurt. The services aren't going to hurt, right? They're only going to benefit. And if you end up not needing them, great, you're discharged and you're done. But if you do need them, then you're in there, and you're getting ahead of it, which is really, really important no matter what age and diagnosis you have. Yes, Caroline.
Yeah, I'd also like to add that it's really important to get on a wait list early when it comes to long-term treatment, like a residential facility. So when you are applying for going to a residential facility, which often lasts months at a time while you are in their treatment, they often have less spots, and because people are there for longer amounts of time, the time frame is very difficult to navigate. So in getting on the wait list early, you have a better chance of somebody canceling or somebody getting there and realizing it's not their style. So you want to get on the wait list quickly, and you also want to prioritize it for longer term interventions like residential treatment.
Great point. I wanted to open it up now to audience questions. If anybody has questions, yes.
I don't have a question, but I wanted to piggyback. There's also at Howard County ER, pediatric ER, there's actually a wing for psychiatry, so they don't have to sit in the ER.
Oh.
Cognitive beds or something. It's the CASA. Yeah. And then there's also Shepherd Pratt has an emergency like urgent care, but specifically for mental health.
Oh.
So Shepherd Pratt's urgent care is very helpful. You can get an appointment and get in pretty quickly. The thing to know though, it's north of Baltimore, so it's the Towson location, which sometimes if you're in the middle of an emergency, that is not a safe place. It's not safe to drive that far because you don't know. So that's one thing. The other thing is it is good to go there for evaluations. They are great, but they don't actually have all the resources right there. So sometimes they're sending your child then to an emergency room. So it is sometimes a multiple pronged approach, but they can help get into partial hospitalization programs. They can do that kind of thing. So if the child can safely make it to Towson, that is a good place to urgently get them seen that has all mental health, but it is a drive.
I think they have virtual.
Pardon me?
I think they have virtual consults.
That I don't know. That would be great if they do.
Thank you.
Can I also
We have
just
another
jump
question?
in real quick too? I just wanted to share, because I'm so glad I'm at a mental health or behavioral health symposium where someone actually mentioned 988 as a resource. So thank you, Dr. Reynolds, and thank you to you for following up. So I just want everyone in the audience to know that we know that 988 is called the Suicide and Crisis Lifeline. But I want to make clear, one, appreciate that absolutely it's available 24/7 for calls, texts, and chat, and available in English and in Spanish. And the other piece that I want to say, though, is that 988 is also an incredible resource if you're just having a bad day. I think people think because it mirrors 911 as an easy-to-remember phone number that you should only call it if you're in crisis. Actually, one of the primary roles of 988 is to provide supportive listening. Someone's having a really tough day, got into a fight with their parents or their best friend or their partner, whatever it might be, and they need an objective listening, active listening ear. That's what 988 does. And EveryMind is actually, 988 is a national lifeline, but it's actually answered by local call centers across the country. And EveryMind is actually the local call center for Montgomery County. So the people that are answering 988 calls and texts and chats are here locally. We understand the resources that are available, so we can provide those resources through those calls, texts, and chats. And so it's not some national number that you're going to get, if you live in Montgomery County and you're calling from Bethesda, Maryland, that you're going to get answered, by someone in California, now that there is geo-routing to route those calls and texts to the local call centers. So just wanted to clarify that and expand that 988 is more than crisis intervention.
Thank you for your emphasis on crisis and treatment, but what about recovery and postvention? So there's a whole life that happens once you get out of the hospital, or once your child is out and they have to go back to school again after they've been partially hospitalized. Could we talk about that and some valuable non-medication resources?
Yeah, I'd love to talk on this. So a lot of hospitals will put kids into a partial hospitalization program, which I personally did not do myself. But one thing I really noticed getting out of the hospital was how overwhelming the schoolwork was. Because especially when you're in high school, it's intensive. You basically have to drop everything that you're doing and fall off the face of the planet for like a week or two. And that's overwhelming coming back to it. And I would say working with a guidance counselor is definitely necessary for that, to like physically make a plan and communicate with teachers individually, because each teacher is going to have different expectations when you're coming back. Some teachers will be very merciful and full on excuse you from everything. Some teachers are not like that, and you have to make up all the tests. And I would say one thing that I had to go through was getting an incomplete on a transcript, which was very difficult because obviously that was not going to be my final grade. But we had to communicate to all of the teachers and to all the necessary organizations, like this student needs the time to catch up. So coordinating with your teachers, having individual one-on-one conversations with them on how to make up those tests, making a big plan overall. And I think it really also depends on what time of year this crisis occurs, because if you're having this towards the end of the year when grades are being finalized, there are ways for the guidance counselors to communicate with the teachers and say, hey, let's close out grades early, or let's find a way to make it so this person is not stressed while they're in the hospital so they can prioritize their own health. I would also say another thing that is really difficult in recovery is balancing the schoolwork and your mental health at the same time, because you have this big pile of work and then you have your own anxieties and depression to deal with at the same time. So that's why PHP is really beneficial, because it integrates those two sides of the spectrum with priorities. I would also say that communicating with your family as well and with your parents, because I think often you're going to get a lot of emails. You're going to get a lot of emails from teachers that are like incomplete, 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 which we just want to verify that that is not permanent, and kind of reinforcing that as the overall message of that part. But yes, communication is a really big aspect of that.
I can add to that as well. Just to quickly add, I appreciate you mentioning, some of the resources that are really helpful for people who are managing crises and things like that. At Compass Health Center in our PHP and IOP, we have like the blessing of having education specialists. And so our education specialists are teachers who work with the patients to really help them get reintegrated into school. Oftentimes, we're having return to school meetings with the schools to make sure that the schoolwork is tolerable, that the school is on the same page around accommodations that patients might need, that parents are heavily involved. And to your question around how to help when crises are happening, at Compass, we have family therapists that are meeting with families 1 to 2 times a week to make sure that they know how to best support their loved ones. There's also holistic care with a psychiatry team member, which is a psychiatrist or nurse practitioner. They also get therapy from a primary therapist 1 to 2 times a week, as well as group therapy. So with that holistic care, we're really trying to prepare people to reintegrate back into their world and to be able to maintain their gains without regressing or needing a higher level of care like an inpatient setting.
Just to add to that, I really appreciate Compass and other programs where when students are coming back to school, they initiate and say, hey, can we have a call? Can we, talk about what this student has been through and what they need as they're coming back? But as a parent, if your program isn't doing that, ask for that. And make sure that a reentry meeting is set so that the school understands what your child has been through and what their needs are. I think the thing that I try to avoid most is bringing the student back too quickly. There is anxiety about what have I missed, I've got to catch up, but I find that if students jump back in too quickly, it's a disaster and it sets them back in terms of their mental health. Sometimes we're even looking at not only titrating back in terms of days or hours per day. You know, maybe someone doesn't come back during a full school day. They'll come back for part of the day, stay till lunch, go home. Prioritize certain classes and maybe deprioritize other classes. Those teachers that you mentioned that are a little bit more flexible, maybe we're not going to those classes right away, you know. So I think tailoring it to the student's need and making sure that they are taking on as much as they can and not too much on a slow basis. It's difficult, and I think, you know, our brother school is Landon School, and we work in tandem with their counselors. Landon, for example, has expanded the number of counselors that they have for lower, middle, and upper, as well as having sort of someone who's directing counseling services. But I think mostly, as I said before, I think educating the kids about what mental health is and what it isn't, how to recognize it in themselves and in their peers, and then the trajectory for bringing that forward. And I think boys are getting, and girls are getting better about that, and less keeping this like secret or not noticing or brushing it off, helping them understand that, you know, this is what mental health is and that it's normal to ask for help. It's normal. Both Landon and Holton have peer education programs, peer counseling programs, and part of the role of those peer counselors is to not be counselors, not be providers for fellow students, but to, you know, be able to make it normal to talk about these things, to make it normal to talk about anxiety, and then also to get a sense of the pulse of a student or a student group to be able to push that to adults in the building.
I will just say also there's an adolescent peer recovery program specifically for young adolescents who have any kind of substance use problems. That's through Tree of Hope. It's a community organization. They are wonderful, and they actually will have a peer who's in recovery themselves reach out to the individual.
All right, and Ed Reed, and I want to thank all of you for the feedback, the comments, the information that you've shared. And I've worked as a school counselor, school administrator, almost 30 years, and I can share with you a couple of things. One would be, it's when you look at a school, it's important as parents or providers is talk with the leadership at the school and ask, what do you do as a school around the areas of mental health, if it's the prevention, the intervention, postvention. I can speak for our school. We've built a culture of having a trusted adult and making sure that we collect data and we look at who has a trusted adult, who doesn't have a trusted adult. The counseling department that I supervise, one of the things that I've tasked my team with is any student who reports that they do not have a trusted adult is to go ahead and continue to build those relationships. I think that's very important. And what I've seen in my work in our team, both with our young men as well as our young ladies, having that trusted adult, they will go in because they've built the relationship. They feel very comfortable coming with their friends or bringing their friends into the counseling office. And when we've dealt with students who've had suicide ideations, it's being able to partner up with their parents, working with therapists, helping them find therapists. Although we don't make recommendations, we have information that we share where the parents can do their research and move forward. But I think the partnerships with parents and parents getting to know who their child's school counselor is, I think that's very important. And also when you look at reentry, that school counselor plays a pivotal role in being able to coordinate even with teachers who might be more resistant and inflexible, then the school administrator can also play a role to help the teacher develop some flexibility. So definitely as parents, know your options, know what's going on in your school, and just around the dinner table, ask your kid in a non-crisis moment, who is your trusted adult at your school?
Any other questions? Okay, well, thank you everybody so much for coming out today. Thank you for joining us and spending your dreary Saturday here. This symposium is an annual event, so it'll be back next May. So keep an eye out. We'd love to see more familiar faces, but thank you so much.